Thank you for your indulgence. I haven't emailed everybody yet. If I get a chance, I will, but yes.
Good morning, everyone.
Go see it.
Good morning. Good morning. Are we ready to? Are we ready to start? We do have quorum, so I'm going to get started. My name is Councillor Chris Moores, and I am the chair of the Board of Health. The board secretary has confirmed that we have quorum, so I'll call meeting number 3 of the Board of Health to order, and welcome to everyone. Today's meeting is being held with board members and city staff participating both by conference, video conference, and in person at City Hall in committee room number 1. City Hall is open to the public, and anyone is welcome to attend the meeting at City Hall today. The public may continue to participate electronically by video conference. This meeting is also being live streamed online at youtube.com/Toronto City Council Live. I ask everyone for their patience with any delays and technical issues. The clerk's staff will connect all remote registered public speakers to the meeting by audio. The list of speakers can be viewed online by visiting the Board of Health page at toronto.ca/council and clicking the speakers box for today's meeting. The board secretary has also emailed the speakers list to all the directors here. Directors, this is a paperless meeting. The board secretary has provided all agenda materials on toronto.ca/council and via CMP, the clerk's meeting portal. Directors, please keep your mic muted unless you wish to question staff or speak to an item, and ensure that your video is turned on. As part of each agenda item, I will ask directors to raise their hand or unmute their mic if they wish to question staff or speak. I will then create a speakers list and will call on directors when it is their turn to speak. When voting on an item or a motion, I ask that directors ensure that they turn on their video and to raise their hand to indicate their vote. Directors, I want to remind you that you must submit and approve your motions by email. Staff are available at boh@toronto.ca to help with motions. All righty. Now that we got this out of the way, I'll start with the land acknowledgement. The Board of Health acknowledges that the land we are meeting on is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishwabic, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work and live on this land. As public health professionals and members of the Board of Health, we recognize the historical and present-day traumas inflicted upon Indigenous peoples. We stand with communities and families as they mourn the loss of loved ones who were sent to residential schools and never returned. We also acknowledge our complicity in ongoing colonial violence. We commit to supporting the efforts of Indigenous groups towards reconciliation and action-oriented practices, including the equitable use of resources. We strive to learn Indigenous histories and collaborate with communities and families so we can create safe spaces that honor Indigenous cultures and ensure that Indigenous perspectives are present in our work and practices. As a Caribbean Canadian, I am committed to continually acting in solidarity with our African, Caribbean, and Black communities, seeking freedom and reparative justice in light of the history and ongoing legacy of slavery that continues to impact our communities across Canada. As part of this commitment, I would also like to acknowledge that not all people came to these lands as migrants and settlers. Specifically, I wish to acknowledge those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. In support of the City of Toronto's ongoing efforts to confront anti-Black racism, I pay tribute to those ancestors of African, Caribbean, and Black origin and descent. Okay, declarations of interest. Are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, please raise your hand or unmute your mic and indicate the item number and the nature of the interest. Seeing none, we will continue. Next, we need to motion to confirm the minutes from the last Board of Health meeting on January 21st, 2023. Chair Roy, all those in favor? All those opposed? That's carried. All righty, we'll move on to the chair's remarks. So again, good morning and welcome to our third Board of Health meeting, even though it's our second in person. Today we will be discussing a number of key items. These items will balance between where Toronto Public Health as an organization has been and where we are moving forward on key priority items. Since we last met, the City of Toronto updated our submission to Health Canada for an exemption under the Controlled Drugs and Substances Act to decriminalize drugs for personal use in Toronto using a Made in Toronto model. Toronto Public Health also released 2022 data for deaths of people experiencing homelessness. There were 187 reported deaths in 2022. Let's observe a moment of silence to mourn these preventable and tragic losses. Please rise if you are able. Thank you. As chair, I have committed to hearing from community organizations and voices alongside the voices present with Toronto Public Health. We all know that community leadership, organizing, and action were critical to our immunization success during the COVID-19 pandemic. However, there are always improvements that can be made. During this meeting, we will hear presentations and receive reports on key areas of work for Toronto Public Health. The final report from the Black Scientist Task Force on Vaccine Equity, a TPH immunization update, and updates to organizational resources related to COVID-19. These are items where it is important for us to reflect on the lessons learned and consider how we can improve Toronto Public Health's future work. As an organization, much of our work will focus on Toronto's post-COVID-19 recovery efforts. A major component of this is the work we will be undertaking around mental health as well as addictions. We have been disturbed by recent comments, photos, and actions taken by a number of individuals who seek to lead this city, using images of videos of those who are in need and those who are the most vulnerable in an attempt to vilify them for personal political gain is not what a future leader of this city should represent. Earlier this year, when Toronto Public Health released its population health profile, we heard very clearly the state of Toronto's mental health. We also know that mental health is a component of overall health and well-being for everyone. The global COVID-19 pandemic has compounded stress and impaired coping for those living with mental illnesses, stretched scarce mental health resources and service capacity for everyone, especially for vulnerable populations, including those experiencing poverty and homelessness, and widen the gap in access to supports and services. The COVID-19 pandemic has taken place during a drug toxicity crisis in 2021. There were 591 opioid toxicity deaths in Toronto alone. That's why now more than ever, we need to turn our attention to this critical issue which affects the entire population of Toronto, our children, our families and loved ones, and our communities. We must continue our work to alleviate the addictions and mental health crises. In addition to the Toronto Public Health Staff Report that provides key updates on Toronto drugs and mental health strategies, Toronto Public Health has also continued with our Made in Toronto approach to drug decriminalization. Addiction is not a criminal issue. It is an issue of health. We must treat people with dignity, respect, and care, not with judgment and shame. I'd like to take this opportunity to thank our frontline workers, nurses, and the entire team at Toronto Public Health for your hard work, your resilience and commitment to saving lives and supporting vulnerable populations, especially those living with chronic mental health and/or addiction. Does a great service to foster a safe and healthy city. I will now ask the Medical Officer of Health to provide her remarks. Go ahead, Dr. Spillane.
Thank you, Chair Moyes, and good morning to the directors of the Board of Health, to staff who are here supporting our meeting, to Toronto Public Health leadership in the room, and to the members of the public who are joining us both at City Hall and online. As the Chair remarked, this is the second meeting of the full Board this term, with both councillor and public members in attendance. And as you heard, it was only in January that we presented the Population Health Profile, a snapshot of the population health of Toronto. The Population Health Profile provides crucial information to aid us at Toronto Public Health as we advise you, the Board of Health, in making policy and governance decisions that are evidence-informed. The Population Health Profile highlighted a number of findings about Toronto's health indicators. These include the decreased life expectancy of Canadians, including Torontonians, the decline in the state of the population's mental health, and the deep impacts of the drug poisoning crisis, the other epidemic in our midst, amongst others. Today, as you've heard, the Board will be considering a number of items that both look back at where we've come from through a global pandemic and the lessons that we've learned from this experience, and where we are going to meet the needs of the Toronto population. The Board will be considering the City Manager award-winning work of the Black Scientist Task Force on vaccine equity and how we can incorporate lessons learned into the work of Toronto Public Health. You'll be receiving an immunization update and hearing about the life-saving protection of vaccines for children, for teens, for adults against dozens of illnesses. You will also be receiving recommendations on the development of an evidence-informed and widely consultative mental health and addiction strategy for Toronto. The mandate of Toronto Public Health is to improve the health of the population, to reduce health inequities, and to prepare for and respond effectively to public health emergencies. In contrast to our healthcare delivery partners, such as hospitals and community-based healthcare, public health achieves its objectives using a prevention-focused approach and working at the population level. With effective governance provided by you, Toronto's Board of Health, and the highly capable team at Toronto Public Health, I am truly hopeful about what we can achieve together. In our current environment, this will require your support for a relentless focus on the public health mandate with absolute clarity about what we are called to do. It will require constant efforts to represent and champion the voice of those who have not traditionally had their voices heard, and those who are most impacted by the decisions made by us at Toronto Public Health and you as the board. And it requires the use of high-quality data and the best available evidence and information to inform resource allocation and to monitor and review our impact. In so doing, we can continue to improve health outcomes for all of Toronto, now and for generations to come. On a somewhat different note, I would like to, with the board's indulgence, take this opportunity to acknowledge the retirement of Gail Bursey, one of our Toronto Public Health directors, effective May the 3rd. Gail has been a valued member of our senior leadership team since 2017. She has served in the public health field for a remarkable 34 years, with the last few years here at Toronto Public Health, providing strategic advice and leading a number of complex portfolios, the most recent being that of Director of Strategy and Preventive Health. Members of the board, Gail is an exceptional leader and a true champion of public health. Gail's leadership throughout the COVID-19 pandemic was instrumental to our success in managing the many aspects of our COVID response. Her strategic thinking, effective issues management, stakeholder management, and commitment to advancing effective public health policy were significant assets to us at Toronto Public Health and were absolutely crucial to our ability to respond effectively during the pandemic. Truly, she was one of the hardest working members of the Toronto Public Health team during the pandemic, and her fingerprints are all over virtually every success we had in our COVID response, both small and large alike. And as you can see, I am emotional about this because she is a very dear colleague to all of us at Toronto Public Health. But with that, I would like to extend my sincere and profound gratitude to Gail for her commitment to public health, her unwavering dedication to improving the health of people in Toronto and beyond. Toronto Public Health leadership, her team, and her colleagues across the City of Toronto, and frankly, the field of public health will miss Gail's leadership, her guidance, her expertise, and definitely her sense of humor. So with that, Gail, we thank you for your service, and we wish you congratulations on your many, many achievements. We wish you well as you embark on your well-deserved retirement. Mr. Chair, I do believe Gail Bursey is available on the line, and if you don't mind, as is tradition at the board, could we just give her a moment to speak to the board?
Happily. Go ahead, Gail.
Thank you very much, Eileen, for your kind words. Can you all hear me?
Yes, we can.
Excellent. Well, I wanted to first say to the board, it's been an incredible privilege to serve the public through such an engaged and passionate board of health as yourselves. You don't find this kind of board at all health departments. So first of all, thank you to the board. And I mean, you didn't make this any easier to get through, but I'll give it a whirl. I also want to say it's been a real honor to work with such a committed group of colleagues here on the senior management team at Toronto Public Health, and also throughout the city, represented in part by Gord Tanner, who's here from Shelters, but many other city divisions really supported me in my work throughout the years, and I thank them. It's been a privilege to report to the well-respected leader, Dr. Eileen de Villa, and I'm sure all of you will agree with me that we owe Eileen a debt of gratitude, for the courage that she's shown throughout the pandemic. And in particular, in those early years, and early months when we had no vaccine, and it was quite uneasy thinking about what lay ahead. And yet she was composed and she was decisive in her leadership to the public to protect their health. And as you can imagine, as a result, it's quite an honor, an emotional honor, obviously, quite an honor to have worked with her in my career. And finally, I want to express my thanks and let you know about my very good fortune I've had in working with some very high functioning professionals who I'm proud to call my staff on my team. I thank you all for your support over the years. I wanted to say that I'm happy to be leaving things in good hands, but I don't sound particularly happy. But you can imagine, it's been quite a few years, and the last 3 being, significantly challenging. But that said, I'm comfortable saying goodbye, at least as comfortable as one can be, given the folks that I will miss. But I'm comfortable saying goodbye because I know the very proud 40 years this year, 2023, the very proud tradition that is Toronto Public Health is in good hands. All the best to you all. Can you put the sound on? I can't hear anything.
Thank you, and happy retirement, Gail. Well deserved. 40 years is a long time. Are you finished?
With that, Mr. Chair, thank you very much. I will turn it back to you.
Mr. Chair?
Go ahead, Dr. Councilor Thompson, go ahead.
Thank you very much, Mr. Chair. Just on a point of personal privilege, and just listening to Gail's comment and Dr. DeVilla's tears, I just wanted to take a moment, again, on a point of personal privilege, to ask this board to reaffirm our position on Dr. DeVilla's leadership. I say this, Mr. Chair, because as you pointed out, there are people who are using the mayoralty campaign and platform to position themselves and use particularly the name of Dr. DeVilla and her leadership through probably the most difficult time in the city's history. And that calls are being made should a particular person become the mayor of this great city, that he would want to dismiss her. And I just want to say, and for all of us who've been here for quite some time, that Dr. DeVilla's leadership has been beyond exemplary. Her commitment, and as Gail has pointed out, during the challenging time when she led this city in providing advice to politicians who then had to make decisions based on scientific and evidence-based information, that we then use that information and to form our position in decisions to obviously make things better from a health perspective for Torontonians. And there are many other municipalities who watched and followed Dr. DeVilla's leadership and the directions and the decisions that were made by council from her input. I think it's important for this board to reaffirm our commitment to her leadership, and her leadership has been life-saving in many, many, many ways through the information that she's conveyed to us as political leaders and to residents of the city. Now, you may not always agree, and it's fine to disagree, but we don't have to be disagreeable in a position that is pejorative in the position that people will take in their comments about Dr. DeVilla's leadership. So I, for one, want to just say to her personally, because of all the conversations that we've had, the meetings that she has attended with my community and many others over the last number of years, how proud I am to be associated with her and how we have benefited greatly from your leadership. And I think this board should reaffirm our position and our commitment with respect to her leadership and her professionalism, and so as to not position ourselves or see ourselves in a way in which she is being vilified where she should not be. In fact, she should be celebrated as the hero that she really is. Those are my comments, Mr. Chair. I don't know if it's possible to move a motion, but I'm happy, to take your direction. But I would move that this board strongly reaffirms our belief and our position in Dr. Davila's leadership, and again, thank her for her ongoing leadership and input to helping Toronto be a safer place.
Thank you, Councillor Thompson. We've all heard your comments, but I don't think we need a motion at this time. We do have processes for that.
I appreciate that, Mr. Chair, but I wanted just to suggest that, should in case. Thank you.
Thank you. I share those sentiments as well. Any other comments from any other members? No? Thank you, Dr. Davila, for your kind words. So we'll proceed with the agenda. So item HL 3.1, developing a mental health and addiction strategy for Toronto. There's a staff presentation on this, so we will hold this item. Item HL 3.2, update on Toronto Public Health Immunization Operations, April 2023. There is also a staff presentation on this item, and there's also a registered speaker as of now, so we'll hold this item down. Item HL 3.3, final report from Black Scientist Task Force on Vaccine Equity. There's also a presentation on this item and registered speakers on this item as well. Items HL 3.4, Toronto Public Health 2023 Risk Management Report. There is a registered public speaker on this item. And item HL 3.5, City approved Toronto Public Health 2023 operating budget. Would anyone like to hold this item? Okay, seeing none. I need a mover for this. Councillor Thompson, all those in favor? All those opposed? That's carried. Thank you. Items HL 3.6, City approved Toronto Public Health 2023 capital budget and 2024 to 2023 capital plan. Anyone want to hold this item? No? Okay, moved by Councillor Bravo. All those in favor? All those opposed? Carried. Wonderful. Items HL 3.7, reopening item HL 2.4 to 2023 Board of Health Committee and appointments for technical amendment. Moved by there was an error in the report, and this is why it's being, okay, so we'll hold it. Yeah, yes, let's deal with it now. That's great. Could you turn your mic on, Councillor Perks?
Sorry, just in the summary, it states that we created the Board of Health Budget Committee and the Performance Appraisal Committee, and somehow it got left out that we also appointed a chair to the Drug Strategy Implementation Panel. So if we could just make, in the notes, make sure that that's added.
Okay. Can we do that? Okay. 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 According to the clerks, the items that were listed here is just a correction from the February meeting. The ones that we passed in February were actually okay. But it's noted, we will add that. We'll add that.
Thank you.
Okay? So you want to move that, Councillor Perks? All those in favor? Do we need to reopen? Okay. A motion to reopen, Councillor Perks.
Motion to reopen.
Thank you.
You're welcome.
All those in favor, all those opposed, carried.
And then I can move the recommendation plus the additional mention that we also appointed the chair of the Drug Strategy Implementation Panel, which we did at that meeting.
It's just a note. Yeah, we'll just put a footnote. Yes, we can do that.
Thank
Okay.
you.
All those in favor, all those opposed, that's carried. Thank you. All righty, and where are we? Excuse me. Okay. Okay, I would like to introduce the following item for new business. Notice of a proposal to amend the procedural bylaw 2-2019 as amended by bylaw 1-2020 and bylaw -2020 of the Board of Health of the City of Toronto Health Unit to govern the proceedings of the Board of Health and its committee. This item is noticed that the board will consider amendments to the procedure bylaws at the next meeting of the Board of Health. The amendments related to electronic participation at meetings and the time required to achieve quorum. I'll ask the board secretary to display the item so that directors can review it. Okay, great. No worries. Okay. I will move that. Any questions about this item? Okay, all those in favor? All those opposed? That's carried. Really? Okay, I have a motion to add new business, this new business. All those in favor? All those opposed? Carried. And to adopt? All those in favor? All those opposed? Carried. Okay, there we go. All these procedural stuff, eh? So we'll now move to the to item 3.HL 3.1. We will begin with the presentation on this item. We will then hear from any registered speakers before moving back to the board. I will invite Uppala Chandrasekara, Director, Toronto Public Health, to provide us with a presentation to the board. I understand Ms. Chandrasekara, I hope I pronounced your name properly, will also be joined by Dr. Tara Gomez, epidemiologist and principal investigator, Ontario Drug Policy Research Network, and Li Ka-shing Knowledge Institute at St. Michael's Hospital and the Institute for Clinical Evaluative Sciences, and assistant professor at the University of Toronto, and Dr. Andrew Bouzere, primary care physician and executive director of population health and social medicine at the University of Health Networks. All righty, you may go ahead. And before you continue, can you please pronounce your name properly, because I know I didn't pronounce it correctly. My apologies.
So, Chair, perhaps I can help with that. I will do a little bit of an introduction to our esteemed presenters and guests today. We are, as you will note, bringing forth a presentation and report entitled Developing a Mental Health and Addiction Strategy for Toronto for the board's consideration. The report, as you'll see, outlines the current status of mental health and substance issues in the city. Toronto Public Health actions as well are outlined in the report, what actions we're taking to promote the mental health of Torontonians and respond to the drug toxicity crisis. And as well, the report outlines work underway to develop a comprehensive mental health and addiction strategy, which we will bring to the Board of Health later this year. As you remarked, Chair, Uppala Chandrasekara, the director responsible for the Harm Reductions, Addictions and Mental Health Program at Toronto Public Health, will be walking you through a presentation. However, before Uppala's presentation, we have some guest presentations from Dr. Tara Gomez and Dr. Andrew Bouzere. As you've heard, Dr. Gomez is an epidemiologist, and she's the Scientific Director of Urban and Community Health at Unity Health Toronto. She's also the Program Director of the Ontario Drug Policy Research Network. Dr. Bouzere is a practicing physician and the Executive Director of Population Health and Social Medicine at the University Health Network. Also in the audience today, if I may acknowledge them, are Dr. Irfan Dalla, Vice President of Care Experience and Equity, and Dale Clement, Vice President of Clinical and Transformation, both from Unity Health Toronto. And the reason we invited these guests to join us today is because in February of this year, Toronto Public Health, Unity Health Toronto, and University Health Network announced new partnerships to expand frontline health care services in response to the escalating drug poisoning crisis in Toronto. This represents the first time that acute care hospitals in Ontario and public health have worked together to offer supervised consumption services, adding a new way of providing essential harm reduction programming and care in Toronto. The new partnerships will see our long-standing harm reduction program at Toronto Public Health, known as The Works, collaborate with St. Michael's Hospital, which is part of Unity Health Toronto, and with Toronto Western Hospital, which is part of University Health Network. We at Toronto Public Health are very grateful to be working closely with our community partners. So given their wealth of experience, we've invited Dr. Gomes and Dr. Buzari to present to the Board of Health on the drug toxicity crisis and interventions to stem the tide of the crisis. So I'll now turn it over to our guests, and thank you once again for being here.
Thank you for having me. Before I begin my presentation today, I want to just take a moment to acknowledge that I am presenting a lot of data and statistics, but embedded within that data are the experiences of enormous loss that have been felt across our city during this crisis. And I think it's really imperative for us to recognize that these numbers cannot adequately reflect the burden that has been borne by friends, family members, other loved ones, and community members who have lost people during this crisis. If I can ask to switch slides. I often show this slide to start because I think it helps give important context as to how we got to this point during the drug toxicity crisis that we are experiencing here today. This is a figure of opioid-related deaths in Ontario since 1991, and you can see that while there was a small incline or an incline in opioid-related deaths throughout the 90s and the early 2000s, in around 2016, we saw this acceleration in opioid-related deaths across the province. And that accelerated again during the COVID-19 pandemic, where we saw nearly an 80% increase in opioid toxicity deaths in just the months after the pandemic arrived. And that has continued throughout the pandemic and has not gone back to earlier levels. Next slide. One of the ways that we can better understand these trends is by trying to look at what the substances are that are really driving them. And I think that this data, which shows the postmortem toxicology from all of these opioid toxicity deaths across the province, is really telling. What you really see here is that this is a fentanyl crisis. This is a crisis of the unregulated or illicit drug supply that is now predominantly fentanyl. And since 2016, when fentanyl entered our drug supply, that is when we saw this increase in deaths. I show the oxycodone line, which is this red line on this figure, because a lot of the conversation around opioid-related harm really started around 2010, around the drug OxyContin that many people have probably heard of. And there was a rise in deaths around that time, but you can see how fentanyl has just dwarfed all of that. And in the last years, we are just in such a crisis situation across the province. One of the ways that I try and contextualize this is thinking about what percentage of all deaths that are happening across the province are opioid related. And when we look at data from 2020, we see that 1 out of every 30 deaths that occurred in our province was from an opioid toxicity event. And this is also an issue that is predominantly impacting our younger populations. If we look specifically at those aged 30 to 39 in our province, 1 out of every 3 deaths in 2020 was from an opioid-related cause. Next slide. The data I've shown so far is for Ontario, but if we focus in on Toronto, which obviously is of great interest to this board, we know that when we adjust for the population size, the opioid toxicity death rate in Toronto is very similar to the provincial average. But when we look at absolute numbers, the numbers in Toronto, because of our large population size, far outstrip any other health unit across the province, with nearly 600 opioid toxicity deaths that we saw in 2021. Next slide. And we can use the evidence and information we have to better understand what is driving these deaths to inform our actions. One of the things we know is that over 90%, so 93% of the opioid-related deaths that happened in this city in 2021 had fentanyl as a direct contributor, and that's even higher than what we see provincially, which is 89%. And in about 2/3 of these deaths, benzodiazepines are also detected. Now, these are substances that we are increasingly seeing within the fentanyl unregulated supply, and they are highly sedating substances. So when they are added to the fentanyl supply, they greatly complicate the overdose response and are making it even more difficult and even more risky for people who use drugs across the city. We're also seeing that at about 2/3 of these deaths, stimulants like cocaine and methamphetamines are involved and directly contributing to these deaths. And this has been increasing over time and during the pandemic, which really shows the growing importance of understanding multiple or polysubstance use and the risks that can come with that, and how we need to provide services that support not only people who are using opioids, but who are using other substances as well. And then we've really seen large changes in the way in which people are using substances. Now, over 40% of the deaths from opioid toxicities that have occurred are occurring when substances are inhaled. And this is a shift away from injection towards inhalation, which really means that when we're considering the services that we provide, we need to make sure that they are not just meeting the needs of people who inject drugs, but also people who inhale drugs as well. And then finally, we see that most of the time, 3/4 of the time, there's no one present to intervene when somebody has a fatal overdose. And this is tied to the criminalization of substance use and the stigma that people feel and lack of services for people to access. And this happens across the province. And so this really reflects the fact that these are avoidable deaths, but when there's nobody present and when people aren't able to access services, they are at extremely high risk of death. At the bottom of the slide, I just try to put this into context with the COVID-19 pandemic, which of course is, an enormous public health emergency that everybody is facing around the world. But I've included these data to help demonstrate the importance of this drug toxicity crisis in our younger population. If we look at all those aged less than 65 in Toronto, there were more opioid-related deaths in 2021. There are 574. Compared to the totality of COVID-19 deaths among those under 60 throughout the pandemic in Toronto. I don't include this to downplay or minimize at all the impacts of the COVID-19 pandemic in our city, but just to show the enormous impact of the drug toxicity crisis among younger populations and how it is leading to enormous loss of life. Next slide. There are also other populations that are being disproportionately impacted by this issue. If we look among people experiencing homelessness, almost 1 in every 6 opioid-related deaths that occurred during the pandemic occurred within this population. We do see that many of these deaths occur in shelters and supportive housing and some of the hotels that were set up to provide emergency shelter during the pandemic. And I think that's important because it demonstrates that we absolutely need to provide people with the dignity of having residence and having housing, but we also have to make sure that we continue to invest in providing people with the networks and supports that they need to prevent opioid-related harm when they are moving into these settings. Next slide. Another population that is particularly impacted by this crisis is First Nations people. We have seen that this is a population with extremely high rates of opioid toxicity deaths over time, but they have actually been impacted even more by the pandemic, where the rates of opioid toxicity deaths increased 132% compared to a 68% increase among non-First Nations populations in that same period. And I think it's important to note that the majority of the deaths that are occurring among First Nations people that are opioid related are occurring in urban areas like Toronto. So this is certainly a population that for this city we need to consider and make sure that we have services that are accessible and culturally appropriate. Next slide. So I've presented a lot of information here. I think that what we can do is try and take this evidence and use it to inform a response. We know that opioid-related deaths have been increasing and the pandemic has not helped that there are increasingly multiple substances either in the unregulated supply or multiple substances that people are using that are increasing their risks, and that the ways in which people are using drugs are changing. And finally, we know that deaths occur primarily when people are alone and they don't have somebody there to intervene. So this all leads to evidence-informed actions that we can take around supervised consumption services, which provide safe spaces for people to use drugs and connect to services, and making sure that those services, whenever possible, also provide access to inhalation, safer supply programs that provide safer alternatives to the highly unpredictable drug supply that we currently have in the city, and low barrier access to treatment when people are looking to and want to seek treatment. And then overlaying all of this is the decriminalization of possession of drugs for personal use. And this ties in with the stigma that many people feel and the fact that if we decriminalize drugs, that can help reduce stigma, help connect people to healthcare services, and also prevent incarceration, because we know that in the time following release from incarceration is an enormously dangerous time for people who use drugs, where there are extremely high rates of opioid overdoses. So all of these can be avoided and addressed in many ways by thinking about decriminalization. Next slide. I've included this to make it clear that there's evidence to support these responses. This is work that has been done by the Centre for Drug Policy Evaluation out of Unity Health Toronto, which looked at supervised consumption sites and fatal overdoses in the city, and showed that there was a 67% reduction in overdose death rates within 1 kilometre of supervised consumption sites after their implementation. And that this impact was actually increasing over time, really demonstrating the importance of sustained and long-term funding for these kinds of programs. Next slide. So in closing, I've mentioned a number of different responses that we can take. I think it's important to recognize that achieving this is going to really require ongoing partnerships and collaborations between organizations like hospitals and public health and community-based providers to ensure scalability and accessibility. The recently announced partnership between Unity Health Toronto, UHN, and Toronto Public Health is a really good example of this, because it provides an example of the first time in the province that acute hospitals are working together with public health to provide supervised consumption services, which we know are so vitally important to the people and communities that we serve, and are really a natural next step in the ongoing collaboration between Toronto Public Health to expand frontline healthcare services in responding to this drug toxicity crisis. Thank you.
So this is the point now we can turn it over to Dr. Buzari.
Turn the microphone on. Oh, thank you so much. I appreciate that and the invitation today to the Board of Health, and honored to be working again with colleagues that have been listed and following Dr. Gomes's very powerful layout of the epidemiology of what is facing our patients, communities, and neighborhoods in Toronto around the toxic overdose crisis. I did want to address the board from the sense of the moral determinants of health, and the sense that we have historically talked about the moral failures of people who use drugs, or individual failures, and the ideology that has furthered the stigmatization and blame and driven these deaths. And for a long time, we've talked about the social determinants of health and healthcare and the hospital network, but I will argue in today's presentation that our failure to act on the social determinants of health as health systems and society writ large, that is the real moral failure, and these are the moral determinants. We cannot continue to speak of the social determinants of health without understanding that this comes with a very real human cost, as Dr. Gomes and others have spoken to, and hopefully looking at the learned lessons through the pandemic in the kind of multi-sectoral approach that we will need and various options and evidence that needs to be in place to address this growing crisis. Next slide, please. I really look at this in terms of trying to see the story of the maps that have laid the groundwork for what we have learned, both through COVID-19, but hopefully coming through various stages of this pandemic. Here you can see to the left the distribution of income in the city of Toronto, and seeing again where neighborhoods that were more white and affluent were actually the ones that received more primary care access by the way of family health teams. And when we look at the primary care access issue in terms of the health system, there's been some excellent research and evaluations done by colleagues Dr. Spithoth and Dr. Kieran, looking at the reality that for people who use opioids, there's actually a tenfold difference in accessing, tenfold barriers in accessing primary care versus people who have diabetes or other chronic disease. And so it's no surprise when we look at the state of COVID-19 in terms of where COVID-19 seized in parts of our city at various waves. It was in racialized communities, low-income neighborhoods, where this was really predominantly about the social factors that we have spoken to. And it is also important, I think, when we look at the leadership of Toronto Public Health and various people in the room who have helped collect this data, where there was initially reticence to why we would collect data around race and health equity in a universal healthcare system. I believe this really exposes that the risk factor for COVID-19 was not race, it was systemic racism and the systemic discrimination that continues to face people that use drugs, and also the partnerships that we've had in terms of the outreach in COVID-19 that was very clear for hospitals and community health centers that have picked up a lot of the disease burden in low-income and racialized neighborhoods in getting vaccines and other life-saving interventions out to people who need it most. Next slide, please. And unfortunately, the same patterns of these maps continue to play out about where we see some of the most suspected overdose calls in the city. None of this, unfortunately, is a surprise, and we see the longstanding groundwork to get here. And again, as Dr. Gomes' presentation has shown, the increase both in the number of calls, but deaths over the last few years. And it's also an area, again, where we have to be thinking about how we get out to address these issues with a data-informed approach, but also the type of community-led responses for us in the acute care sector, or those of us working in healthcare, as to how we can best address these needs. And this is something, again, when we look at these statistics or these maps and these real images, the reality is this is about, again, human life and the human currency. And when we think about some of the evaluations that have been done to show that just in the last year alone to the last 2 years, we're talking about over 25,000 life years that have been lost in Toronto to the overdose crisis. And again, it disproportionately impacting neighborhoods where there's the intersection of homelessness and poverty and much worse access to many of the social factors we've discussed. Next slide, please. I think, again, the very powerful outlay of the evidence around safe consumption sites, the evidence around access to treatment, other mediums that are needed to reach people, knowing that this is going to require a number of different interventions to be in place, is something that we have seen through the literature and, again, I've seen in practice. The other saying, unfortunately, I think that as the chair has mentioned, again, that you cannot provide treatment to people who are dead, and the importance of life-saving interventions. We've seen this on safe consumption, and this is actually a paper by Dr. Gomes and colleagues Dr. Kola and Sereda that actually looked at one of the other options that have been put in place in terms of a safe supply given the toxic drug overdose to opioid and to fentanyl. The benefits, again, we cannot disconnect this work from the hospital and acute care sector, the primary outcome needing to be around keeping people alive. But we can also see that the program had success in reducing the number of ED visits when we are looking at the constant duress the health system is under, the importance of being out there and saving lives. Again, it is very clear that every medium, every option and intervention needs to be in place to save lives and address the sustainability of our healthcare system at play. Next slide, please. And this is really, I think, to close in terms of 3 tangible areas as well that we really need to see the implications take place. One is the need for more community outreach and the community health ambassadors that, again, were heroes throughout the COVID-19 pandemic. We cannot lose the momentum and traction in this connective tissue that was built in between our acute care sector and public health systems in getting the kind of supports that Dr. Gomes and others have spoken to that is so crucial to keep people alive, and especially now managing the crisis for people who are under 65, but again, in terms of the chronic disease that is compounding with the overdose crisis and issues around homelessness and poverty. We also have to see this full continuum of care and these kind of partnerships to take place, whether it's from stabilization centers to different supports of safe consumption sites. These are the things that need to be put in place, and the partnerships of the pandemic cannot be pulled back. And as you can see from the map around where the overdose calls are happening, we actually need more access to safe consumption sites, more access to the kind of low barrier treatments that people need. And it would be remiss not to state, again, given the importance of talking about the moral failure of our health systems and society, that if we do not move on the upstream solutions of housing options and basic income, we'll continue to see populations, and especially people who use drugs, continue to be in this devastating situation. And again, it being more about the policy disdain towards people who use drugs driving this despair than any failure on the individual level. So thank you very much for this opportunity today.
So thank you to both Dr. Gomes and Dr. Buzari for their presentation, which clearly has provided a very solid foundation for the work that lies in front of us. As we call up the next part of the presentation, and which will be delivered by my colleague Upala Chandrasekhara, just a reminder for all those in the room that we're now talking about the public health perspective and the public health objectives, which are, of course, to improve the health status of the population, to reduce inequities in health, and to prepare for and respond effectively to public health outbreaks and emergencies. And a reminder, as I mentioned in my earlier comments, our goals in public health, our way and approach of responding, and the way we achieve our objectives is through a prevention-focused approach and working at the population level. And to Dr. Buzari's point, this inevitably involves working on the social determinants of health themselves, these very important conditions within which people live, work, and play. As you'll see in the presentation coming up, this is especially relevant to the development of the mental health and addiction strategy, which will have to focus, yes, on downstream service delivery options, and from a public health perspective, equally as important and arguably more important, upstream health policy options. So with that, I will now turn it over to Upala for the presentation. And thanks again to Dr. Gomes and Dr. Buzari.
Thank you so much, Dr. Davila. I also want to thank Dr. Gomes and Dr. Buzari for providing the evidence and the recommendations to inform our work. So today's presentation, Developing a Mental Health and Addiction Strategy for Toronto, will provide an overview of the current context of mental health and the drug toxicity crisis in our city. Next slide, please. Provide an update on our current mental health promotion work and actions to address the drug toxicity crisis, and share information about the forthcoming mental health and addiction strategy. Next slide, please. As was presented to the Board of Health back in February in the Population Health Profile for 2023, mental health issues and mental illnesses have worsened during the pandemic, with several population groups disproportionately affected, including women, 2S LGBTQ+ people, seniors, Indigenous people, racialized populations, people with disabilities, as well as children and youth. The COVID-19 pandemic has negatively impacted mental health and increased the need for services and interventions, exacerbating existing gaps for mental health care. I think that many of us have also experienced our own personal challenges over the last few years of the pandemic. It's really important that we all acknowledge this and support one another. As you heard from our guest speakers today, prior to the COVID-19 pandemic, the drug toxicity crisis was already having a devastating impact in Toronto. And during the pandemic, the situation worsened. We just received data for 2022 just a few days ago, and it shows that there continues to be a significant increase in the number of drug toxicity deaths in our city. Preliminary data for 2022 shows that there were 499 opioid toxicity deaths in Toronto. This is a 69% higher than 2019. It's important to remember that each of these deaths are preventable. These deaths are caused by an unpredictable, contaminated, and unregulated drug supply. In addition, the stigma and discrimination against people who use drugs creates barriers to accessing treatment and support. The fear of criminalization is also a reason why people hesitate to access health and social services. We have also examined data on adult and youth alcohol and cannabis use. Data for 2022 shows that among adults, 80% reported alcohol use and 33% reported cannabis use in the past 12 months. Data for 2021 shows that among youth in grades 7 to 12, 32% report using alcohol and 17% reported cannabis use at least once in the past 12 months. Next slide, please. In order to address the complex and interconnected issues driving the increased mental health and substance use related needs in our city, we require both a downstream service delivery response and an upstream population health response. Next slide, please. In 2022, Toronto Public Health identified 4 interim priorities to guide our actions. These priorities include responding to the COVID-19 pandemic and other emerging public health issues, addressing the drug toxicity crisis, promoting mental health, and rebuilding public health functions. As you can see, 2 out of the 4 priorities at Toronto Public Health are focused on addressing mental health and substance use issues in our city. Given the importance of this work, in fall of 2022, we created a brand new program called Harm Reduction, Addictions, and Mental Health. Our program brings together both the downstream service delivery response and the upstream population health response. Embedded across these priorities, and indeed across all of our programs at Toronto Public Health, are core principles that guide our public health actions. These include a commitment to reducing health inequities. As you know, health inequities are the differences in health outcomes that are unfair, avoidable, and systematically linked to social inequality and the social determinants of health. Things like poverty, homelessness, racism, just among a few of the factors. We are using both a health equity and a social determinants of health lens in the development of the mental health and addiction strategy for Toronto. Next slide, please. The Board of Health report before you today provides updates on the substance use and mental health promotion programs at Toronto Public Health, including clinical and harm reduction programming at the Works, our work in mental health promotion during the COVID-19 pandemic, our work on refreshing the Toronto drug strategy, the Integrated Prevention and Harm Reduction Initiative and Shelter Overdose Response Service, which is provided in partnership with the city's Shelter, Support, Housing, and Administration Division, as well as alternative to drug criminalization. I'm truly proud of the team at Toronto Public Health for all of the efforts to respond to the mental health substance use needs over the past few years, particularly as we have also been faced with an unprecedented global pandemic. In this presentation, I'll elaborate on 2 of the components of our program, namely our downstream service delivery response through the Works program and our upstream population health response through the Drug Strategy Secretariat. Next slide, please. As you've heard already, Toronto Public Health provides harm reduction and treatment services through the Works program, which includes a supervised consumption service, needle exchange service, opioid agonist therapy, and injectable opioid agonist therapy. And we mobilize over 60 agencies across Toronto to offer safe supply, harm reduction outreach, and supplies and services at over 100 locations and access points across the city. The Works program is truly a leader in harm reduction and clinical programming in our city. Next slide, please. The supervised consumption services that we offer through the Works program respond to overdoses, prevent communicable disease transmission, and provide health and social supports. Toronto Public Health, we gather data from other supervised consumption services in Toronto, and in 2022, across 10 out of 11 supervised consumption services, which includes our program, The Works, we saw over 96,000 visits to our clinics, and over 1,800 overdoses were reversed. In 2022, at the Works program, we supported more than 21,000 visits to supervised injection, and we prevented more than 500 overdoses. That's more than 1 a day. Next slide, please. This map, you saw Dr. Buzeri presented as well. This map represents neighborhood-level data on suspected fatal and non-fatal opioid overdose-related calls to Toronto Paramedic Services, and this map is for 2022. I want to thank our partners at Toronto Paramedic Services for routinely supporting us with this valuable data, and I also want to thank our epidemiology team at Toronto Public Health for this data analysis. This data is useful in identifying hotspots where harm reduction initiatives can be targeted and enhanced across the city. On this map, the 2 red colors correspond to 8 neighborhoods with 100 or more suspected opioid overdose-related calls. This map demonstrates that the opioid toxicity crisis continues to be concentrated in the downtown core of our city, with 7 out of the 8 neighborhoods with the greatest number of suspected opioid overdose-related calls located in the downtown. The downtown neighborhoods include downtown Yonge East, Moss Park, Church Wellesley, St. Lawrence East, Bayfront, South Parkdale, the Young Bay Corridor, Harborfront, and Kensington. Next slide, please. As Dr. Davila mentioned, and as our colleagues mentioned earlier, Toronto Public Health, Unity Health Toronto, and the University Health Network announced new partnerships to deliver supervised consumption services earlier this year. This responds to the ongoing need for supervised consumption and harm reduction services in the downtown core. Partnering with hospitals offers an opportunity to expand the WORKS program. The current program can be reconfigured to create 2 smaller programs to co-locate with St. Michael's Hospital and Toronto Western Hospital. Partnering with hospitals also provides an opportunity to enhance partnerships to better coordinate referrals for clients, such as primary care, inpatient services, and wound care. In addition, with adequate funding resources, co-locating with hospitals provides an opportunity to increase our services to 24 hours a day, 7 days a week. Next slide, please. I'll now switch gears and from discussing our downstream service delivery response to the drug toxicity crisis, and I want to focus for a moment on our upstream population health response. Under the direction of the Board of Health, Toronto Public Health has been developing a public health approach to drug policy since 2017, when the Toronto Overdose Action Plan recommended convening a community dialogue to explore this topic. In 2018, the findings from the community dialogue led to the Board of Health first calling on the federal government to decriminalize the possession of drugs for personal use within the boundaries of our city. Since then, this call has been consistently reiterated. It was followed by a request from the Board of Health that Toronto Public Health undertake broad consultations and community engagement on decriminalization. This has included the creation of a decriminalization reference group and several working groups, roundtables, interviews, and a public consultation survey. The Toronto Drug Strategy Implementation Panel, responsible for overseeing and guiding the implementation of the Toronto Drug Strategy since its inception, has also been key to advancing our work on a public health response to drug policy. Broad public engagement on decriminalization has focused on ensuring input from equity-deserving people, including people with lived and living experience of drug use and incarceration, African, Caribbean, and Black community members, Indigenous communities, and people experiencing homelessness. Additionally, over 6,000 members of the public provided input through a public consultation survey. This engagement informed an initial exemption request to Health Canada in January 2022, and the updated exemption request was submitted to Health Canada just last month. Next slide, please. First and foremost, as has been stated many times already today, drug use is a health issue. By decriminalizing the possession of drugs for personal use, we are proposing a shift away from a criminal justice approach to drugs. We are proposing an alternative approach to drug use that is evidence-based, that takes care of people who use drugs, and that takes care of our community by ensuring public safety and community well-being. The decriminalization of drugs is conceived of in different ways in different contexts. In Toronto, we have prioritized developing a model of decriminalization that is appropriate to the local context and meets the needs of all people within the City of Toronto. Decriminalizing the possession of drugs for personal use is not legalization. I'll repeat that. Decriminalization is not legalization. Substances will not be available for legal purchase like alcohol and cannabis. Decriminalization means providing a non-criminal alternative, like a referral card, to the possession of drugs for personal use. Certain locations, such as supervised consumption sites, they are already decriminalized. These are locations where people can use drugs under the supervision of health professionals without fear of criminal penalties, and that is the service that we provide through the WORKS program. We know that decriminalization will not prevent all of the harms associated with substance use, but it is an upstream policy intervention to prevent the harms associated with criminalization. and in the long term, create a societal shift away from the stigma and discrimination that people who use drugs experience, which is a barrier to accessing health services. We continue to have ongoing conversations with Health Canada on our exemption application, and we expect that these conversations will continue as the model and the implementation details are further developed, and as we work towards our goal of having an exemption being granted for our city. The proposed Toronto model enhances public health and public safety considerations, advances equity for those most impacted by the harms of criminalization, and is fully endorsed by Toronto Public Health and the Toronto Police Service. Dr. Davila and Police Chief Myron Demkew have established a strong partnership and continue to work together to address the range of health and legal issues relating to the proposed model. This is a work in progress, and the updated submission to Health Canada reflects all of our partnership work to date, with much more collaborative work ahead in the days and months to come. Next slide, please. Finally, I'd like to share some information about our work underway to develop the mental health and addiction strategy for Toronto. This strategy will include public health strategies for mental health promotion and substance use prevention, as well as the refreshed Toronto drug strategy. It will outline goals and concrete actions for coordinating City of Toronto initiatives in this area. It will also include measurable performance metrics for monitoring progress on the concrete actions identified. This strategy, it's not just for Toronto Public Health. Rather, this strategy is about what all of us can do. Healthcare providers like our hospital colleagues, community-based providers, housing providers, social support providers, and the various different divisions all across the City of Toronto. This strategy will be about how we can all work together to address the mental health and substance use related issues impacting on our city. Next slide, please, and this is my final slide. Similar to the engagement I spoke about earlier for decriminalization, we have been engaging in broad consultations to inform the mental health and addiction strategy. This has included people with lived and living experience, community agency leaders, service providers, researchers, clinicians, and policymakers, including Toronto Public Health and City of Toronto staff. Consultations have also focused on those with unique community needs, such as women, 2S LGBTQ+ people, African, Caribbean, and Black communities, Indigenous populations, as well as specific topics such as prevention, harm reduction, treatment, and enforcement. This work is also being informed by a reference table whose membership overlaps significantly with the Toronto Drug Strategy Implementation Panel membership from the previous term. The next phase of engagement to inform the strategy will focus on building out the mental health components of the strategy through key informant interviews. We look forward to presenting the mental health and addiction strategy to you all later this year. As I conclude my presentation, I want to end by taking a moment to thank all of our staff in the Harm Reduction, Addictions, and Mental Health program. Our frontline staff in the Works program are working downstream, saving lives every single day. Our staff in the Strategy Secretariat, they're working upstream on population health policy, focusing on prevention. All of our teams are working hard to respond to this crisis. I'll be honest, there are some very difficult days in our program. This work is really challenging and at times devastating. It's an honor to work alongside these dedicated staff at Toronto Public Health, and I'm truly grateful for all of their efforts. Thank you so much for listening and for this opportunity to share with you our work to date and all of the work that lies ahead of us.
Thank you, Ms. Chandra Sikera, Dr. Gomes, and Dr. Buzeri. I do have one person on the list. Members may ask questions to the presenters. Councilor Thompson, I believe you had a question.
Thank you. Are there visiting members who may wish? Do we ask for visiting members?
Yes, visiting members, do you have a question?
I will stand down.
Sure. Go ahead, Councilor Chang.
Thank you so much, and thank you for the heartfelt presentations. It must be so hard to watch us lose people, especially when, there are some clear solutions on hand. I wanted to ask about loneliness as a factor towards mental health and addictions. There are, I think there is existing research about the connection, and it seems to me that it's an area that we're not investing in as a city, as a province, as a country, and in fact, you may know that the UK and Japan have ministers of loneliness because they've identified the negative health outcomes. So I'm wondering if there's been any data collected with regard to loneliness and access to social support structures relating to the opioid crisis, homelessness, mental health, and addiction.
Through the chair, thank you so much, Councillor, for your question. Data that I'm intimately aware of is through the Canadian Mental Health Association. They have done a lot of research and look into this area of loneliness. When we think about the mental health determinants, right, the social determinants of mental health, there are three key factors: access to economic resources, freedom from discrimination and violence, and social inclusion. And that is a key factor that we're focusing on as we build this strategy. And you're absolutely right, a lot more work needs to go into that. We've seen the devastating impacts of loneliness over the last 3 years of the pandemic as well.
Because it seems to me there's been a spike during COVID, which happens to also be when a lot of us were locked down. And I wonder if there was any direct research with regard to the overdoses and the loneliness resulting from lockdowns.
Absolutely. With regards to data that we're using to inform our strategy, we are doing a broad scan of data around this issue, as well as many other issues as we inform and develop the strategy. But we certainly can have a distinct focus on it in the strategy.
Thank you so much. I will be moving a motion about it. Oh, and I think there's somebody else who wanted to maybe speak.
But I do think the big piece, Councillor, that you can't disconnect and disentangle is that we moved a lot of people from communities throughout the pandemic. And it was a valiant effort to try to get people next to housing where we did not have housing as a human right. But as Dr. Gomes put forward, the people who are lonely or isolated in shelter hotels or in other settings and not having that network was seen as a potential driver. And I think if we're addressing the issue of loneliness, it has to have a health equity lens as well around the points that were raised around social exclusion, but also around poverty and housing. And if we're looking at this displacement, which is happening now across the country in streets and tents and encampments, if that element of not ensuring that people have social connection both to their own communities, but the kind of community health worker and peer worker piece, which were the heroes in the shelter hotels, or the real peer worker element where there can be that connection, I do worry that the loneliness piece can be seen in isolation from some of the broader social determinants and issues that we've seen drive these death rates.
Right, certainly it is a complex issue, and I did visit 11 Macy, where it's a supportive housing site where a lot of the residents, when they moved in, had to go into isolation. They weren't allowed to connect socially because of COVID risks, and that actually made it even worse because when they were unhoused, they could be in community. So sometimes, we have to really consider all of these factors to paint a fulsome picture. And I just have one last question. Oh.
Yeah, I was going to say, Councillor, I think you hit upon a very important point there, and certainly it was echoed by my colleagues, Upala and Dr. Buzari. These are no question, there are challenges around social isolation, and it has its impacts on health, yes, mental health and physical health as well. There is a growing body of research in respect of that. But as you just heard, and as you yourself just mentioned, there is a complex interplay between a variety of different factors, and so it does take some real time to tease that out, and it is, I think it just speaks to the challenge and how significant it is, the one that we're trying to deal with in front of us.
Yeah, thank you. Thank you for all of your efforts. And just one last question, which is about the decriminalization. And I'm just wondering if there is research about if one municipality decriminalizes, but the ones around it don't, is there an impact, or is there an effort to work with surrounding municipalities so that we could have a more cohesive implementation?
Through the chair, absolutely. So in the jurisdictions that have decriminalized, BC, for example, it was a provincial approach, and then we've had statewide approaches in the United States. In Toronto, it is a municipality approach. We are very much in contact with our neighboring jurisdictions, both on a public health front, and I certainly know that the Toronto Police Service has also been in touch with their colleagues in the immediate area. So we're continuing to work together collaboratively. And also, there have been several jurisdictions within the GTHA that are also looking to move forward with decriminalization, as York and Peel and Durham. They've been ongoing conversations. And we know that in Hamilton as well, there's been some keen interest. And so we have been liaising with our colleagues regularly and sharing information. As you know, this is a new approach to policy in this province. And so we are working closely with our municipal partners on this.
Great, thank you so much, and thank you, Chair, for the opportunity.
You're welcome. Next on the list is, I'm going to say Dr. Thompson. Councillor Thompson. I used to work with the Dr. Thompson. That's why I keep Councillor Thompson. And to Dr. Gomes and Buzari, you can also come up to the front here in case there's a question for you. Thank you. Go ahead.
I'll wait for them to say. Mr. Chair. Thank you very much, Mr. Chair. Through you to the presenters, and I offer comments, and I want to profess my remarks to suggest I agree in principle with what is being stated. But my first question to you is, does decriminalization actually save lives?
Through the chair, absolutely.
Okay.
One of the key things, the reason why people hesitate to call 911, the reason why people hesitate to access service is the fear of criminalization. And so if our goal collectively as a society, as a Board of Health, as healthcare providers, is to get help in the moment that's needed, absolutely this does.
Fair enough. So then may we look at perhaps defining a definition for that so that the broader public could have a better understanding of what decriminalization means? Because when we talk about it, we look at Oregon, for example, Measure 110, decriminalization created such a situation there where everything was decriminalized, and you had the reverse effect of what the intentions were. This is just a comment. So my next question to you, though, is that I didn't see in the report where you talk about recovery communities, for example, and I looked at Red Deer, Alberta, and what they're doing, and they're looking at expanding. I think that it's really important for us to associate and combine our approach with respect to decriminalization with respect to treatment and recovery and that expanded investment, but I don't really see that as part of your report in terms of the details. I'm wondering why.
Through the chair, our application to Health Canada actually outlines this clearly in terms of decriminalization alone will not address the drug toxicity crisis. We actually need a full continuum of services and supports, downstream services, frontline services. In order for decriminalization to be effective, we need so many more health services in this jurisdiction, including a 24-hour crisis center, which we've been advocating for a long time, including this Board of Health.
Right. So recovery communities, though, is a little bit more than just a crisis center and recovery. I'm just wondering, are we looking at expanding our efforts into that area? Are we looking at requesting that both the province and the federal government, as they've done in Alberta, and they've got a new facility there, I think it's about 95 bed or 75 beds, and they're looking at expanding 5 more as part of this effort in terms of, yes, supporting decriminalization, but also looking at dealing with addiction, which is a major part of the issue. Because you're not saying, or you're not suggesting that just simply decriminalization is the answer, but I'm just wondering why not the emphasis on something like recovery communities, because I think that's extremely important.
Yeah, I don't disagree with you, Councillor. Recovery communities are absolutely important. And it's, also really important to keep in mind that mental health issues and substance use issues are episodic in nature.
Right.
Right? So we have periods of recovery surrounded by periods of illness. And so with regards to what's forthcoming in our strategy, we are going to be talking about measurable metrics and goals for the city. And I think a recovery community is one example of the types of services that we need to focus on and enhance in our city.
So,
And sorry, if I may, through the chair, just one little point. Again, Upala spoke to this. It is a full spectrum of options that needs to be available, all the way from upstream to downstream. Just a reminder that, of course, as public health, our primary concern is on the upstream side of things. That's where our strength is, and that's the value add we add to the system. We are, of course, and we will continue to advocate with the provincial government to ensure that the appropriate healthcare services are made available, and the full spectrum. It may be, some community-based services, some recovery-type services, just all the options that are available, recognizing that different people will require different healthcare options, but that's for healthcare to be the lead on and to deliver.
fair enough, thank you. I only have 30 seconds left, so I'm going to ask you 2 questions and you can answer. The Portugal experience, in terms of everyone has said they get it right. I know I was in Portugal, spoken with the mayor there and so on, and they seem to do that. I'm just wondering how we're looking at that. BC, you talk about decriminalization. I visited the harm reduction facility in BC probably about 15 years ago, and it's not perfect, but it is better than what was there before. So I ask you that question. And then the final part of my question is, with respect to private facilities that are offering treatment and support, I note that you mentioned UHN and the hospitals and public health working together. I didn't sort of see that emphasis with respect to the private sector's engagement and on-ramp opportunity to engage. I'm just wondering, how are we dealing with that? Because that could be very helpful. Alberta is using, in fact, a Toronto-based company to run their recovery communities, and it's going fairly well.
Through the chair, thank you for the question. With regards to other jurisdictions, Portugal in particular, as well as British Columbia, we absolutely looked at the evidence and the model. We're in regular contact with our colleagues in BC as well. And our focus in Toronto has been a made in Toronto model, because we know that the client population is different in Toronto. We know that our challenges, our social challenges, the social determinants of health access is different in Toronto. And we also know that the rates of death are very different in Toronto. And so our model is very much focused on a Toronto-specific model. With regards to the private sector, certainly we are absolutely open to working with all service providers as we move towards more support and enhanced services for our community. Certainly, our partners to date have been from the public sector and frontline healthcare providers and community-based providers. But certainly, I would say we're open to all partners who would like to work with us to address this crisis.
Thank you. Thank you, Mr. Chair.
And if I may, Mr. Chair, just to add a little piece to that, of course, the important part is making sure that we're achieving all the goals of public health. Yes, improving health status of those who require that support, but I just want to point out again that component around reducing health inequities. So regardless of which partners, which treatments, and which policies are actually, advanced on, these are the goals of public health that we constantly keep in mind and that we're always monitoring for. We heard from our partners, Dr. Gomes and Dr. Buzari, how very important this is. And so you can rest assured as members of the board that these are top of mind considerations for us as we proceed with our work.
Okay, thank you. Any other questions from, thank you. Dr. Zhao, go ahead. Director Zell.
Great, thank you, Mr. Chair. So I have a question for Dr. Gomes. It's regarding the fentanyl contamination with benzos and tranquilizers. It's becoming much more challenging to resuscitate people using your traditional Narcan kit. Have you heard anything about whether Zimhigh might be introduced, the high-dose naloxone?
There we go. Not specifically. I think that one of the challenges with the contamination with benzodiazepines, for example, and tranquilizers is that naloxone will not reverse that part of the overdose. And so what I think is happening at the community level is that supervised consumption services and other frontline workers are having to adapt, and they're seeing a lot of unusual, I would say, overdoses that are occurring where they're providing best support to people when they are highly sedated for hours at a time. And that puts pressure on everybody. Not only is it dangerous for the people who are using substances, but it can be difficult if you're running a supervised consumption site and somebody is highly sedated and technically the site should be closing, and that then, moves people out of the community into first responders and into hospitals when that happens. So I think the challenge is less around needing higher dose naloxone and more so around needing to find ways to avoid people's exposure to the really unpredictable drug supply that is contains so many different substances at this point, which complicates the response, not only for people who are experiencing the overdose, but the people around them who are trying to respond.
Thank you. And my second and last question is just regarding, you mentioned that inhalation of substances contributes to a large amount of the overdose deaths. In terms of suggestions for managing that other than providing harm reduction, like STEM kits, for example, is there anything else that you recommend for managing the inhalation aspect?
It's a great question. When I speak with people who are using drugs in the community, there's a real disparity in people's experiences. Some people say that there's been a push towards inhaling more drugs because people feel like they can control the dose more and feel safer. But then when we look at the fatal overdoses, we're seeing that there are a large number of fatal overdoses with inhalation. And certainly some people I've spoken with have experienced the opposite, that it actually is more dangerous and more difficult to adapt the dose. So I think it speaks to the fact that people are using substances in many different ways. One of the very pragmatic things I think to consider, and I recognize that it is not entirely straightforward from an infrastructure perspective, is but to think about the supervised consumption sites that we have, and that they are primarily focused on injection drug use. It is much simpler to implement within an indoor setting, and how we can adapt those to make them safe spaces for people who inhale drugs as well. Because if we don't do that, we are going to be leaving a large proportion of people who are using drugs unable to actually use those in spaces that can support them.
Great, thank you.
Thank you. Next is the Director Chandra Balan.
Thank you. Thank you for your presentation. I wanted to touch on how many visits were done by the private sector. So you had said 21,000 through the WORKS program, but how many was it that was outside of the WORKS program? I know you said it. I'm sorry, I don't have it written down.
Through the chair, we engaged 10 out of 11 supervised consumption services, including the WORKS program, and we saw over 96,000 visits to our clinics and over 1,800 overdoses reversed.
Okay, so majority of the visits have been outside of the WORKS program. Is that correct?
Yeah, last year we had 21,000 visits to our clinics.
Okay. The reason I'm asking is because I just wanted to know if it was based off of manpower, or if it was because of their relationships with the clients. If they have better outreach, should they be included in the conversation when we are co-locating with the hospital? So kind of going back to now I'm saying Dr. Thompson too, Councillor Thompson's point, if they'd be included in the discussion.
Absolutely. So an aspect of our program at the WORKS is an outreach program. And so we do actually have 3 vans as well, where our teams, they go out to different parts of the city to provide education around harm reduction, to actually provide fresh needles and other kits, and also to refer people to services. And so outreach is a big component of what we do. And we also have a perimeter outreach team with our location currently that goes into the immediate neighborhood to encourage people to come and use our services. Absolutely.
Through the chair, just a little bit further in respect of the works. One of the limitations in respect of, the number of clients that we're going to see is in fact our physical space. So I think that's an important component. I would also point out that one of the unique aspects of our service at the Works is that we are serving a particular population, and I think when you look at the different supervised consumption services and harm reduction service offerings throughout the city, we each have a slightly different population that we serve. And I think when you look at the data for the Works, we are serving a particular population in the downtown core, and those who have been chronically homeless in particular. So when we look at our services, that's been one of the overriding features for our service over many years now. The other component, just going back to an earlier question, we are on the subject of safer inhalation facilities. That's one aspect that we've long advocated for, and we're actively exploring that opportunity and trying to figure out how to make that a possibility. So I just didn't want to leave that hanging. Thank you.
Thank you.
Okay, thank you. Next is Councillor Bravo.
Thank you, Chair. To Dr. Bouzere, I just wanted to pick up on something that you said in response to Councillor Chang. We hear a lot in the community that, and from professionals and people working with people who are housing insecure, that housing insecurity and homelessness itself has a detrimental impact on mental health. Can you comment at all about that, on that?
I'll get the microphone right. I think fundamentally, we have to be clear about homelessness as a public health crisis. If you look at the evidence, many hospital partners, community partners have been collecting this, evaluating this across the country for years. Homelessness not only can exacerbate mental health conditions and substance use, but really when you look at life expectancy. So when we talk about homelessness as a terminal condition, it's very clear that people who are chronically exposed to homelessness or surviving homelessness, they live half as long as the general public. So every single health condition that you can think of, and that's where we talk about this inextricable link between homelessness and health, is worsened. And we see this with a chronic stressor. And again, a lot of this also spurring from the pathologies of poverty. You can't separate those two as well. So we've seen a lot of other literature around the impact of chronic poverty on people's mental health. And again, this runs in a bi-directional fashion as well, again, with the root cause on our failure of housing as a human right. So I think the move in terms of the understanding of homelessness as a public health crisis and this intersection with the toxic drug overdose crisis, which Dr. Gomes and others have mentioned, taking more lives for people less than 65 than the pandemic, and as Dr. DeVille has mentioned, as its epidemic of itself, we need to see a urgent crisis response to this, and trying to disentangle this, whether it's about issues of loneliness or poverty or homelessness to drug use, will keep us in the same cycle and ultimately leaving thousands of lives lost and thousands of life years lost that, again, every evaluation has shown over the last 3 to 5 years.
Thank you. Agreed. And then on another point that you made about relationships and their importance, can you comment on whether those relationships, I think I heard that it's the trusted relationships within community that help to ameliorate some of those conditions, and that can be with community-based service providers, but I think you also mentioned that it can be the relationships that are formed among and within communities that are experiencing extreme forms of exclusion. Is that correct?
Correct, and I would add, I think from a place of humility, I think we have to be very clear that marginalized populations, again, people who have been most impacted by the toxic drug overdose crisis, do not trust hospital systems, and for a good reason. I think there's an issue that we have to be clear about. There is mistrust of hospital systems, of some elements of healthcare. We've seen, again, some of the data that was raised in terms of people who are chronically homeless or who have long-term opioid therapy have a much harder chance of getting access to primary care, to let alone the kind of care they receive in an emergency department or a hospital ward. We've seen the push now from hospitals in having to partner with community agencies and people who have lived experience as to how to bring trauma-informed care, both in our hospital settings, but also the type of partnerships. And I think we have to think very differently about the healthcare teams that we want to deploy, knowing that trust is such a fundamental aspect, and for many years it has been broken down, and for decades, given a lot of the histories of hospitals and their role. And I think this is something where, again, partnerships with public health, community leadership, and bona fide healthcare members like peer workers or community health workers, which we saw again through the pandemic where there was trust, and we've seen this from the Black Scientist Table, the Black Health Equity Working Group, much of this for the community health centers of having community health ambassadors actually brokering these conversations around uptake of the COVID vaccine. And we can't lose those learned lessons from the hospital system, or I'd argue for the healthcare system writ large.
Right, so on the healthcare side, it's clear what you said. I just want to recapture that from the public health perspective, then the ecosystem that we're part of really does involve the very on-the-ground organizations and workers that have more direct relationships of trust, right?
Yes, people with lived experience, and you've seen that ultimately. Again, I think we have to be engaging people who have had lived experience of using drugs or of continuing to, or experiencing and surviving homelessness in all facets. And I think this is something where we've seen the evidence show that it is life-saving to have that kind of engagement and to build that sort of trust.
Thank you.
Okay. Thank you. Go ahead, Director Roy.
Hi, great presentation. One thing that I didn't hear a word about is food security as a conversation. When I'm looking at Scarborough's map, the one that you talked about, the suspected opioid overdose calls to pandemic, the deep orange pockets are the pockets where the food bank use is the maximum. So there is certainly a correlation along with housing, of course. And just to point out or question that, is that something that we're also looking at and conversing about?
Through the chair, as we develop the mental health and addiction strategy for Toronto, absolutely we are focused on the social determinants of health, and access to safe, culturally appropriate food is absolutely something that's important. I think, we really do need to consider what aspects of the mental health and addiction strategy do we want to have emphasis and focus on, because everything is about mental health. And so I think that will be the challenge and opportunity for you as the board as we bring this forward in the fall, actually to think about what aspects of the strategy would you like the city to focus on in the short term, and what aspects do we want to focus on in the years ahead. But absolutely, food security is very important, and we've seen that as a major issue that impacts overall health and well-being during the pandemic. Thank you for your question.
Thank you. And Director Ozude.
Thank you so much, Dr. Gomes and Dr. Buzar, for the presentation. For Dr. Gomes, I really shuddered when in your presentation you said, I think it was in the 30 to 39-year-old group, 1 in 3 deaths were opioid related. Is that correct? It's not a young group, but it is a millennial group. Like it is a young adult group. So I'm curious, is there some unique age-related factors that go on to increase the risk of opioid use and death in this group?
Sorry, thank you for the question. Certainly when we look at the clustering of deaths that are occurring, they tend to be in the 20 to 49-year age group. And that 1 in 3 number, I think, every time I see a number like that, I feel like I have to check it 10 times because it just doesn't seem possible. But I think that, what it really reflects is that in these younger age groups, there aren't a lot of actual causes of death. So these are generally, a healthy time of your life. You're past that early, any sort of early childhood risk of death. You're not quite in that older age group where you might be more likely to have cancer or heart disease and these other factors that lead to death. And so it really speaks to the fact that this is, one of just the leading reasons why we might be seeing this accidental death in this population. We know that there is a high degree of substance use in those ages as well. I think it's important to note, and just to reflect for some of the other conversations that have happened, that in Ontario, about 2/3 of people who died had a diagnosis of an opioid use disorder, which also means that there are a large number of people, especially in our younger adolescent and young adult populations, who are using drugs intermittently, recreationally, and because of how unpredictable they are in terms of toxicity and what is in that supply, are at risk of death as well. And we know that that is a population that is likely a younger population that uses drugs recreationally as well. So I think there are a number of factors related to employment in the construction industry, related to ways of using drugs intermittently, as well as developing opioid use disorders, and just the fact that there aren't a lot of other competing causes of death in these younger age groups.
Okay, thank you. And my second question is, you also mentioned that for people who are incarcerated or previously incarcerated, their risk of opioid use is quite high right after release. Is that correct?
Yeah, so there's some work that has been led by one of my colleagues at Unity Health Toronto, showing that in the days and weeks after release from incarceration, people who have previously used drugs have a very high elevated risk of opioid overdose for a couple of reasons, primarily because a lot of the time they're not able to access treatment or their drug supply within the incarceration system. They lose their drug tolerance. When they leave incarceration, they no longer have the same tolerance to the supply they had before. They're often left without any other option but to go back to their pre-existing networks. And when they use substances, because of that decreased tolerance, they're at much higher risk of overdose.
Okay, all right, thanks for that. I'm thinking about it now from a public health and a health equity lens. We know that Indigenous populations are overrepresented in the carceral system, Black populations as well, the LGBTQS populations as well. What does this mean for designing interventions, right, from a health equity lens?
Absolutely. I think that's one of the underpinnings of approaches to decriminalization is the overrepresentation that we see in Black and Indigenous populations within the incarceration system and within the prison system. And when you bring that together with not only the risk of overdose when you leave, but also the impacts of incarceration on ability to secure employment when you leave jail settings, as well as losing those networks of support, when you've been incarcerated for some time, I think that it's really important from a public health perspective to be considering, the racism that exists within the incarceration system and the way in which criminalization of substance use specifically has disproportionate impacts in these populations, and how ideally approaches to decriminalization can help prevent some of that as well. I don't know if you want to follow up on that.
That's it for me. Thank you.
Thank you. Councillor Malik, go ahead.
Thank you very much, and thank you for the presentations and the information. My first question is about the recommendation number 3. The Mental Health and Addictions Committee proposed to pull together relevant city divisions in Toronto Public Health, focused on coordinating the City of Toronto's policies and programs related to mental health and substance use. What do you see the role of people with lived experience in that committee?
Through the chair, thank you, Councillor, for your question. This idea really came about because there's so many different city divisions working on the topic of mental health and substance use, and we wanted to provide really an anchor table to coordinate services and supports for the city. All of our reference panels have engaged people with lived experience, so I anticipate we would do the same with this panel as well.
And so what does that look like?
So in terms of recruiting people with lived experience to participate, so with regards to the individuals that participate now, they are provided compensation for their time. And so we value their expertise and advice to us. And so with regards to this panel, we would use a very similar approach.
sorry, I appreciate that people's time is valued, but in terms of their inputs into the work of this committee and the significant, impact that their perspective and their involvement could have in this, especially if you're talking about the type of coordinated table that this can be. Can you speak a little bit more to what their actual involvement might be?
Absolutely. I mean, at this point in time, we do not have a terms of reference for this committee. I think there's an opportunity to think through what role the board would like for these individuals to play, but certainly with every advisory committee that we've had to inform this process, it hasn't been a token participation of, for example, one person with lived experience. There's been several people with lived experience engaged, providing input, being part of the discussions as we've been developing this strategy. I think Dr. Davila, you wanted to add?
Yes. Yeah, through the chair, Councillor, just wanted to be clear that we see this participation as absolutely fundamental, and we see it as, again, as my colleague has just said, it is about really meaningful participation so that we are able to provide services that actually address needs as they exist, and to adjust services as needs inevitably change over time. So this is exactly the approach that we take, and we see it as a very important one. Yes, there's compensation, but it is meant to be absolutely informative in terms of the service provision.
Okay, thank you. I mean, as this comes along, it would be good to hear with a little bit more specificity about how people with lived experience and their contributions are going to be reflected in this committee. My next question is about substance use, and would all substance use be considered an addiction in your view?
Through the chair, mental health and substance use are a spectrum. And so when we look at the development of this strategy, we really are looking at the spectrum. We know that with regards to some substances, there are beneficial uses for it, right? We know, for example, the impact of CBD on things like epilepsy. And so we really are looking at the spectrum and the continuum of care that's required when we're looking at this strategy.
So I guess what I'm hearing is that not all substance use would be considered an addiction necessarily. So would all aspects of drug use or substance use fall within the scope of this strategy?
Yes, absolutely. So the founding kind of principles and the guiding principles that we're looking at, it's really about community well-being for the city. And so when we're looking at, I mentioned this earlier, it's really important to remember that mental health issues are very episodic in nature, as is substance use. And so there's periods of recovery surrounded by periods of illness. And so when we're thinking about substance use, it could be, beneficial use, casual, non-problematic use, all the way to problematic use and substance use disorder. So we're really looking at the entire gamut of issues that are before us when we're thinking about the strategy for Toronto.
That's it. Thank you. Trustee Srishkan-Raja.
Thank you. Through you, Mr. Chair, thank you, staff, for your presentation. I have a question for Dr. Bosey. I'm sorry if I'm mispronouncing that. Please correct me if I am. I really appreciated the maps of where overdose calls come from. And so it, of course, it's concentrated in the downtown core, but could you speak more to whether those tend to be more in institutional settings, like shelters and hotels that act as shelters, versus where in the city, if they're happening more in private home settings?
Yeah, happy to let Dr. Gomes speak to that as well. Happy to speak to the element in terms of the concentration. I think as the question was also raised in terms of looking at the hot spotting as has been referenced, it has to be very clear the common denominator is poverty. So that's about food insecurity. It's issues again around chronic homelessness and sheltering spaces. That's what we've seen play throughout in terms of the pandemic and also what we're seeing in terms of these maps. and also growing income inequality and different divides in certain neighborhoods that were historically higher income as well. So I think what we've seen is, as the presentations have laid out, that there is a change in shifting in the pattern, and I think the element of being able to have social connection, whether that's with a community health worker or a peer worker or your own community, whether that's in a sheltering or a hotel site, has a major determinant about whether someone survives a fatal overdose. And that's one of the elements that we've seen. And again, what we've seen throughout the maps is the disparity in access to treatments as well. And so that's what's driving many of the rates that you're seeing in the maps.
Okay, so there, from what I'm hearing is, so it's not, there isn't data available to show which parts of the city there's more likely to be deaths in shelters versus homes, private homes.
Well, I think from the data that we've seen in terms of the release around deaths happening in shelters, many have come from fatal overdose, but there's also deaths happening in people in their own private settings as well. So I think I'm just trying to better understand the question. I think,
I think what I'm
happening in both settings.
Yeah, what I'm trying to get at is you mentioned that we need more sites, and I just wanted to know from your expertise where you think the placements of sites would be the most beneficial.
Well, I think that's been, and I don't want to speak for the city staff or the other colleagues, but I think the data-informed approach as has been laid out is pretty clear. If they're seeing a rise, and we have in different neighborhoods of where there are greater needs, and again, where that is intersecting with other issues of food insecurity to chronic homelessness and other elements in being able to get supports or primary care access, as was laid out in the maps, that those would seem to be the areas that we'd want to see more supervised consumption sites. And again, the myriad of supports that need to be there, from safer supply to other harm reduction supports and safe and supervised consumption sites.
Thank you.
If I may, through the chair, I think if I can just emphasize one point. Dr. Buzari spoke about a data-informed approach, an evidence-informed approach, and that's a fundamental tenet of how we actually conduct ourselves at Toronto Public Health. So no question, you're going to continue to see us present these kinds of data, the kind of work that Dr. Gomes and colleagues do, really, really important in terms of informing our decisions. I do think it's important to note that we're also seeing the impact. So Dr. Gomes, you presented a slide specifically that showed how, there was a significant reduction in overdose-related deaths in and around supervised consumption services. 67% reduction is what I recall from the presentation. So it's those kinds of data that we're constantly using. But I think to Dr. Buzari's point, we're talking about some very complex issues, and it's not just, there are a multitude of factors that are unfortunately intersecting and interplaying with each other. That are giving rise to the phenomenon that we're seeing out on the streets and in our communities right now. So it's, we look at all the data in combination, observe and monitor, and seek to adjust our interventions, ours that are within our purview as public health, and advise our healthcare colleagues where they're the more appropriate stakeholders around actions as we see that might make a difference premised on the data we have.
Thank you. And maybe a follow-up question on that. Is it safe to say there are more safe injection sites in the downtown core than the other parts of the city?
So through the chair, we do see a number of supervised consumption services and harm reduction services, certainly in the downtown core. That is a reflection of where the need is the greatest. That's not to say that the need does not exist in other parts of the city. The maps clearly delineate that, but in the current environment, we're putting the resources where they're most needed and seeking to increase resources in other parts of the city that are unfortunately under-resourced or less resourced at this point in time.
Thank you. And I think that's sort of the rationale for my question of if deaths in the suburbs, as we saw in the maps on the two ends of the city, are they more likely to happen in private homes, therefore justifying perhaps more investments in safe sites. But thank you. My last question for Dr. Chandrasekhar. With the events that happened in BC, with the decriminalization, do you think we're at a better place in terms of where we are in getting the feds to approve the ask that we're making?
Through the chair. I'm a social worker too, not a doctor.
Oh, sorry.
We have been working, in partnership with Health Canada. We actually have, I think, bi-weekly or monthly meetings with them, and we have been speaking with them for well over a year now. And so, your guess is as good as mine in terms of timing around an approval, but we certainly have been engaged in conversation, answering all questions that they have, and they've been very helpful in connecting us with colleagues in BC as well. So I would say our partnership is very valued, and it's a strong one, and we continue to work with them.
Thank you. And my last question.
Oh, I'm sorry.
We're done? Okay.
Yes,
Thank you.
Thank you. Most of my questions have been answered, but I do want to revisit, follow up one other questions that was alluded to. You mentioned that the overdoses that happened, they're happening in the downtown core, and the areas that you mentioned, majority of them are in my ward in Toronto Centre. And also, too, there's a lot of services in the downtown core, and as a result, people come to the downtown core to receive those services, and now we're inundated. So what steps are we taking to address some of the deficiencies in regards to services in other parts of the city and beyond? Are we looking at the regional strategy as well? I know we're looking at Toronto made solution, but it's beyond our borders as well. Perhaps someone could address this. If you can't address it, that's fine, but...
Through the chair, I think this is a very complex, interconnected issue, and we're seeing this across the board also in terms of gentrification, right? As people find more affordable housing outside of the downtown core, that's where they're moving, but the services continue to be provided in the downtown. And I think as we have more innovative programming in Toronto, we are going to start to see more and more people come here because we have the services available here. And I see this, I also am responsible for the dental and oral health services program. We see that in that program as well, because we have a robust, excellent service. We see people coming from all other areas of the province to use that service. So I think we can expect to see that kind of flow just simply because the services are more available here in the city of Toronto. Dr. Davila.
And through you, Chair, if I can add, we are in constant and active conversation with our partners around, the city, whether it's in respect of dental services or harm reduction services. This is a regular point of conversation, and I know that our colleagues around the city are actively looking at what they might be able to do to enhance their service offering in this arena, and as well in the dental services. It's challenging, no question, but it is a constant point of conversation.
Thank you. And just my last question too. You mentioned about the 24/7 SIF injection site, and you said it's needed and it's necessary, and I totally agree. And it depends on funding. So is it going to happen, or you're hoping it happens? And just to follow up to that, in regards to the partnership with Unity Health and the other health network, I can't remember now, is that a 24-hour site that's happening?
Sorry, University Health.
University Health, thank you. Is that going to be a 24-hour site when it does open?
The chair, couple of things. Currently, we are working with our partners at Unity Health and at University Health Network to in search of new locations where we can partner. And so at this point in time, we do not have a particular site or building selected yet. We're still looking for a location with both partners. And this is the opportunity with partnering with hospitals that are a 24-hour operation. Once we have new sites selected, we would love to have a 24-hour operation. And we have already engaged the province in these discussions in terms of funding for a 24-hour operation, because right now we are funded for a 12-hour operation. But I think this is what will be really beneficial when we establish our partnership with the hospitals. We can increase our referrals to inpatient care, to emergency department services, to primary care. There's so many, the possibilities are endless, but we would love to see our service become 24 hours with adequate funding.
Thank you. It sounds like you're asking us to move a motion to request that from the province. That's what I'm hearing.
That's your prerogative, Chair.
I'm sure the directors are listening attentively. Thank you so much for your presentation. Again, Ms. Chandra Sikera, Dr. Gomes, and Dr. Bazari. Much appreciated. And we'll move, we do have one deputant for item, sorry? No, we don't? Okay. Give me a moment while I figure this out. Thank you very much. To the directors, do we have any speakers to this item? We just did that, but. Okay. Okay. So, Councillor Thompson.
Thank you very much, Mr. Chair. There is a motion that I'm going to move on behalf of Councillor Chang, which is the isolation motion. I'll just assume that you've read it once the staff is able to put it on the screen. Mr. Chair, you may want to just restart the time. It says 5:39. And it's the motion's there, and so I'm moving it on her behalf. It's important, and I know that the comments from staff was that it is something that's part of the inclusion. First of all, let me thank the staff and the presenters for a very informative presentation and an effective presentation. We know that this is a issue that's compelling, that's challenging, and you know, it's the, I guess, the boil the ocean approach dealing with mental health and you know, drug addiction certainly is not one that we are taking. It's an approach of looking effectively as to the things that can work. I note that there's a tremendous amount of confusion when we talk about decriminalization in the public sphere. I think it's really important for us to educate and provide the appropriate definition in terms of what it is and how it works and so on. My edification and education on drug strategy came many, many years ago with the late Dr. Sheila Brasseur, who was the Chief Medical Officer of Health at the time. And at the time, her approach and the response from the public in general is that this doesn't work and we should never do it and so on. And of course, she was able to provide evidence that it does work. One of the things that she would say was like, look, you know, if we can avoid someone breaking into your home trying to get money to buy drugs and what have you, versus a situation where you know, we're able to assist them. And part of it was around policing and so on, and how the police would respond. And I want to commend the police because they have, as you've heard, partnered with obviously all of the different stakeholders, of course, led by Dr. Davila and the Board of Health. There's a lot of work that's being done universally around the world, and I looked at the Portugal experience with respect to what they're doing. They are moving in the right direction, and I think that we need to model ourselves from that. Certainly there are things for us to learn from BC and its harm reduction program and so on. Additionally, though, it's really important that it really will require resources and investment, and I think it's important that politicians at all level listen to the experts and to ensure that resources are applied and put in place. I don't think that it's a Toronto thing or condition. It really has to be that all areas, and I think the question was asked, you know, what happens if you just focus on Toronto and not other areas and so on, what happens? Well, of course, if you have all of the different services here, people are going to come here. I think that it has to be more broad-based. But I think that we need to also look at the reading I've been doing in the recovery communities. I think that's extremely important. And we look at Marshall Smith, who is the Chief of Staff to the current Premier of Alberta. And I've read about his experience. He was someone addicted to drugs and so on. And today he is the Chief of Staff for the Premier of Alberta. And it's not about politics, but it's just about a person being able to get help and assistance through having, the ability to offer an alternative approach, which I think is really important. So it's not just the focus on decriminalization and, thinking that's the solution. And I know that staff did not suggest that that is the case. Talking about safe consumption, I think that's really important as well. I've seen it with my own eyes when I visited the harm reduction facility in Vancouver. While they did draw the curtain when they were trying to help someone to recover and to actually save their lives, I understood that worked based on my limited experience in that one scenario, but I know that the people working in this field are often the experts, and they do say that this does work. So I think that we have to focus our attention on the inequities that exist. We realize them, and we now have to stop simply talking about it and deliver on the reality of investments that needs to be made, and also the understanding that with respect to our investment, the benefits will accrue to all of us. Certainly it's a huge challenge and it's a huge responsibility. So thanks again to everyone for their work, and it's ongoing, and I'm sure we'll have more input to be added later. Thank you, Mr. Chair.
Thank you, Councilor Thompson. Any questions to staff or to the mover on this item? Okay. Seeing none, next speaker is Councilor Bravo.
Thank you, Mr. Chair. I have a motion. If we can share that. In the meantime, I'll just describe it. It's a request for the Medical Officer of Health to ensure that as this strategy is being developed, that there's a recognition and a differentiation between the approaches and challenges related to mental health and distinct from drug use and addictions. And I raise this for a couple of reasons. One is because right now we know that, as we've heard repeatedly, that all ages and all demographics in Toronto have emerged with worsened mental health out of the pandemic. It has a significant relationship to other areas of work of public health, and also because of the ways that we saw in that we can see in public health's work, how inequitably that impact is felt in the city. I also raise it because at the last meeting of council, we talked broadly about community safety, and there was a lot of discussion about mental health in Toronto. And I think that it's essential that as the city council continues to deliberate on what that looks like and continues to speak of mental health, that there is a public health lens, a public health perspective on this conversation in relation to mental health, which would be different than the approach taken perhaps in other areas of the city. And I think it's a really important contribution. And finally, I also raise this because, as the chair indicated in his opening remarks, and as others have spoken of, this is a very tricky time right now politically, and there's been a lot of mobilization of stigmatizing comments, mobilization of tropes that are problematic and destructive to people, and I think it's be important to have this this area of work be allowed to grow sort of along two different tracks to make sure that as we discuss mental health in this city, it's the public health approach is centered, and the public health approach has an important voice in the discussion.
Thank you, Councilor Bravo. Any questions of staff or the mover? Okay, seeing none, Councilor Malik.
Thank you very much. I also have a motion. And the motion is the Board of Health direct the Medical Officer of Health to continue to support the work of the Drug Strategy Implementation Panel while these new comprehensive strategies are developed. And I guess to start building on Councillor Bravo's motion, we can see that there's a strong correlation between addiction and mental health, but both of these issues have unique aspects as they relate to the work of public health. And while I'm very happy to support the continued development of the comprehensive mental health and addiction strategy, it's important that the work of the drug strategy over the past more than 15 years does not take a backseat while we move forward. As we wait for this final report in the fall, we will be a year from the last election and more than 14 months at that point since the last meeting of the implementation panel, if we wait. And that's a fourth of our term. And that's too long to wait to not have a place at the table for those with lived experiences, paramedics and public health workers. It's too long for them not to be involved in the way that we've seen them capable of doing over the last many years. It's important, of course, that we're not creating work for a team that is pulled in many directions, as we saw. But we do need to ensure that we continue to support the city's drug strategy as issues arise that we heard about with the urgency and seriousness today. And as the chair of the drug strategy implementation panel, it's vital we allow this committee to continue as we move forward with our city's strategy on addiction and mental health.
Thank you, Councillor Malik. Any questions for the mover or for staff on this item? Okay, seeing none. Councillor Perks, go ahead.
Thank you. I'd like to speak in support of the two motions that we've just had, and I'll do them in order. I think it's vital that we understand that while the concurrent issues of being homeless, using drugs, and having mental health problems require certain strategies, that there are instances of drug use that have nothing to do with mental health. And there are mental health problems that have nothing to do with drug use. And there are housing challenges that have nothing to do with either of them. These are separate and sometimes overlapping issues. And I think it's very important that as we devise this strategy that staff are proposing, that we remember those separate pieces and we don't come up with just one piece that tries to deal with both. In terms of the motion that Councillor Malik moved, I've had the very great privilege for about 10 of the last 16 years chairing the drug strategy implementation panel. So I wanted to say a couple things about the importance of that work. First, and this is important, when Toronto devised its drug strategy, it did so in, with a very broad consultation, much as what's proposed here. And in the strategy, which was signed by Councillor Thompson and 4 other members of council, it's a City of Toronto document, it laid out clearly that the one most important recommendation, and this is right from the introduction, is that there be an implementation panel that included people from different branches of the public service, but also people who use drugs. And that body, the implementation panel, would take the lead in making policy recommendations for how to achieve the ideas in the drug strategy to Toronto City Council and to the Board of Health. I just want to give you a couple of examples of how that worked. So for example, Toronto was one of the 2 cities that led the work to create safe injection services in Canada, the other being Vancouver. And in the design of the safe injection services here in Toronto, we were very deliberate in making sure that people who use drugs got to design things like the physical layout. One of the most interesting conversations I've ever been part of as an elected official was that conversation about designing it. And it was interesting. It was here in City Hall, and we had people who, self-reported as people who are currently using opioids, sitting down with the superintendent responsible for the drug squad at the City of Toronto, talking about issues like what happens if there's a 911 call from inside the supervised injection site. That's a very, very thorny and tricky issue. And we were only able to come up with a design for it because both the enforcement arm and the people who use drugs work together to design it. Similarly, the implementation panel led work on some of the issues with drug use in Toronto community housing buildings. And a result of including everybody in that conversation, this is just one of like 30 things that we're doing in TCHC buildings, is a human rights statement was posted in all TCHC buildings, making it clear that people who use drugs have human rights and have the right to shelter as well. And that was a very important part of the conversation for staff and other tenants and enforcement and security guards and all of those various people who interact with that issue to understand that just because you use drugs doesn't mean you're not allowed to live somewhere. You can't get to those kinds of things just by looking at data. And you can't get to those kinds of things just about thinking about upstream policy development and downstream service delivery. You need to actually center in the conversation people who use drugs, people who provide services to people who use drugs, and all the different branches of the public service. So I think what Councillor Malik has proposed is vital. We don't merely consult, we give leadership in decision-making to the people whose lives are impacted by the decisions we're making. That's why I think we need to recenter and re-energize the drug strategy implementation panel. Thank you.
Is it okay? I know I'm just asking, I moved a motion through Councillor Thompson. Would I be able to just say a few sentences? I won't take 5 minutes.
Okay, go ahead quickly.
Is that okay?
Go ahead.
Okay. Thank you. Just this is regarding a motion. I'm grateful for Councillor Thompson for moving. Social inclusion is a key social determinant of health. We have a lot of data about addiction and about mental health, but I'm concerned without intentionality, we might miss a tremendous opportunity towards preventing mental health challenges and substance abuse. There is data that does exist that shows that people living in poverty have an increased risk of loneliness. And since substance use and mental health also show increased risk in the same population, it would be important to research an upstream approach that includes the addressing loneliness. And I know that there's very technical health data that we have looked at today that doesn't talk about this piece, and certainly that's the fire that we are immediately wanting to address, but just including loneliness or social isolation is just a few steps back and looking at it from a more macroscopic perspective. So I'm just hoping that we can consider it as one of the factors that we can consider in our implementation of a strategy. Thank you.
Thank you, Councillor Chang. Are there any directors online who would like to speak? Because I can't see everybody or everyone from where I am. If not, I can go next. Okay, then I'll go next. So I do have a motion as well. Clerks can put it up, please. So this is on behalf of the Toronto Youth Cabinet. And I circulated a letter from to each members here. It says, endorse the Toronto Youth Cabinet's joint statement on addressing the rising mental health crisis facing children and youth in Ontario. And number 2, request the city clerk provide a copy of the board's decision to the Minister of Education. Again, we all know what's the pandemic, how it has affected the mental health of children across our city. And we see it manifest itself in many ways in some of the behaviors that's happened around the city, but also around our schools lately as well. I know that I've had many meetings with the Director of Education and the Board Chair of the TDSB on this. So it fits quite well with what we were just talking about. So I hope that will be accepted by by the Board of Health. So thank you. And seeing no other speakers, Should we go to the vote?
Sorry, I just had a point of clarification.
Go
Was
ahead.
the motion by Councillor Thompson on social inclusion or social isolation?
Social isolation.
Isolation? Okay, thank you.
Let me confirm with the clerk. What's the wording? Isolation. Okay, thank you. Yes, okay. I was told Director Krishmer had a motion, but I don't see her online. Do you know what the motion is? Do you have it?
I'm here, Chris.
Oh, here we are. Oh, thank you so much.
Councilor Moise? Yeah, I'm here.
You want to go ahead and speak?
Sure. Can you hear me?
We can. Go ahead.
Okay, excellent. Thank you. Just want to begin by acknowledging Dr. Eileen Davila and your colleagues within Toronto Public Health for the presentations that we've received today. I am advancing as it relates to the development of a mental health and addiction strategy to be developed by the city, that we consider that we do this as it relates to connecting with Indigenous communities more meaningfully. So the motion as presented reads, the Board of Health requests that the Medical Officer of Health undertake an Indigenous-specific and distinctions-based approach to ensure that the mental health and addiction strategy be co-developed in true partnership with Indigenous organizations and communities to ensure that approaches and actions are supportive of the unique needs on Indigenous people living in Toronto. And so we can be, I think, actionable and very thoughtful in the ways in which we want to advance that work. And I just want to comment that the impetus for that is, that motion is that the root cause, I think, for addictions and mental health is often, as we know, linked to trauma and or loss. And in the context of Indigenous experiences, this can be linked to intergenerational trauma and a collective experience of loss and displacement. Our overrepresentation across a litany of plight statistics and in connection to broader notions of well-being suggest that we require Indigenous approaches that are informed by communities and organizations through an Indigenous worldview and lens. Lastly, we are often underrepresented in citywide strategies, and in an effort to ensure we are included meaningfully, I believe a distinctions-based approach to this work is an imperative to ensure that, again, we are crafting culturally informed solutions for urban Indigenous Torontonians. Now we'll go.
Thank you very much, Director. Any questions for the Director or to staff on this item? Okay, seeing none. Can we go? Anyone else wants to speak? Nope, okay, so let's do the vote. Okay. Are you going to put it on the screen? Or? Okay. All right. Awesome. So we're going to start from the top with Councillor Thompson with his motion. We'll put it on the screen and then we'll vote on the item. All those in favor? All those opposed? Carried. Second item is from Councillor Bravo. No worries. It's coming on screen shortly. It's okay. Okay, item on screen. All those in favor? All those opposed? That's carried. Third item is from Councillor Malik.
Can I get a recorded vote on this, please?
Sure. Councillor Malik's recorded vote. Clerks can do that. Yep, go ahead.
This is a recorded vote on motion 1 by Councillor Malik for item HL 3.1. When I call your name, please indicate your vote. Director Bravo? In favor. Director Chandrabalan? I can't hear. Can you put your microphone on?
Yeah, so that
I thought my mic was on.
Yeah.
Affirmative.
Also, it's also for the directors on the line, so they could hear you.
I'm sorry, that was in favor?
Yeah.
Thank you. Director Kretschmer? Can you pull that down?
Yes?
Can I have your vote, please?
In favor?
Thank you. Director Malik?
In favor, thank you.
Thank you. Director Mantis?
In favor.
Thank you. Director Moise?
In favor.
Thank you. Director Uzode?
In favor.
Thank you. Director Perks?
In favor?
Director Roy?
In favor?
Director Singh?
In favor?
Director Shrish Kandaraja?
In favor?
Director Thompson is not here. And Director Zhao?
In favor.
Thank you. The motion carries unanimously.
Thank you, Madam Clerk. Next item is my item. Yep, it's okay. The next motion was for me. It's okay. All those in favor? All those opposed? That's carried. Next item is from Councillor Kreshmer. It's waiting for it to come on screen, and then we'll vote. Yeah. All those in favor? All those opposed? That's carried. And now we're going to adopt all the items as amended. All those in favor? All those opposed? And that's carried. Wonderful. Good work, everybody. Yay, we got through one item. It's after 12. Okay. We're getting better. Item HL 3.2, update on Toronto Public Health Immunization Operations, April 2023. And we do have a presentation, so let's start. Dr. Davila will introduce the next item and the person presenting.
So thank you, Mr. Chair. Yes, we do, for this item, have an update on Toronto Public Health Immunizations Operations and a presentation that will be made by my colleague and our Deputy Medical Officer of Health, Dr. Lamptey. So I'll turn it over to Dr. Lamptey now.
Thank you, Dr. Davila. Thank you, Councillor Moyes and members of the board. I'm here to provide an update on some very busy activity in the immunization program at Toronto Public Health. And if we can go to the first slide, please. Here you see a graph from Public Health Ontario's immunization updated coverage report for school-based programs for the 2019 to 2021 school years. And you can see, just broadly looking at this line, that the trends in immunization coverage for the school-based vaccines that are provided in schools by public health units over time, you can see that line dropping during the pandemic years. So there are 3 vaccines in the school-based immunization program, the SIP program, and these vaccines protect against hepatitis B infection, human papillomavirus, and 4 strains of bacterial meningitis. These are truly life-saving vaccines because human papillomavirus and hepatitis B virus infections can lead to various forms of cancer, and bacterial meningitis can cause serious disease and death. So over the 3 pandemic years, coverage among grade 7 students for these vaccines decreased substantially, and that is because of pandemic disruptions, including school closures, which meant that the vaccines were not routinely provided. So if we can go to the next slide, please. In recognition of this, since September 2021, Toronto Public Health has been providing access to school-based vaccines as part of public health recovery work. Hepatitis B, meningococcal, and human papillomavirus vaccine have been available in our Toronto Public Health mass immunization clinics for eligible students who missed doses due to the pandemic. That was since September 2021. Since September 2022, last year, nurses from Toronto Public Health have also been going to grade 7 and 8 schools to restart the school-based program. Middle schools, where children are in grade 7 and 8, are the traditional place where the school-based program routinely operates. This year, from January to March 2023 and ongoing, SIP vaccines have been offered to all high schools and provided at most high schools for catch-up. This is a new and extraordinary recovery effort. This specific outreach with clinics at high schools is in recognition of the need for focused attention to grade 9 and 10 students who did not have the opportunity to complete their SIP vaccinations when they were in grade 7 and 8 because of the pandemic. In addition to the universal offerings, such as the offer to all high schools for catch-up, when TPH identifies schools in higher needs communities, TPH nurses work with school principals to encourage and enable the hosting of a clinic. This is in response to the reality that some communities experience more barriers to accessing vaccine. TPH has offered high schools with lower coverage of SIP vaccines in priority neighborhoods a second on-site SIP clinic this spring and additional promotion of the clinics. And as you can see here on the right-hand portion of this slide, in total, we are well on our way in catch-up. TPH has administered over 150,000 catch-up school immunization program doses since September 2021. The scale of this uptake by families to participate in clinics, at mass immunization clinics, and at school-based clinics demonstrates that more than one channel can meet family needs and can produce incremental additional increases in coverage. We can go to the next slide, please. Like I mentioned, there has been significant progress towards closing the gap in SIP vaccine coverage. This graph shows the rates of compliance with the recommended vaccine doses in the school-based immunization program for students in the 2004 to 2009 birth year groups. These were the children that were in grade 7 to 12 last school year. On the right of this graph, there is a blue box that shows the SIP vaccine rates in the school year 2017 to 2018 before the pandemic. So it's like a comparison of what we would have expected in routine years. Now, I do have to note that each birth cohort in Toronto is about 24,000 people. So in Toronto, we have about 50,000 students in middle school and 100,000 high school students. To give you some perspective, some of the other health units in our province have an entire population across all ages of 150,000. So it really does take a great deal of effort to move the population marker on cohorts this large. From June 30th to 2022 to March 3rd of this year, 2023, vaccine rates for students who were in grade 7 to 12 last year increased. This is positive. And for example, if we look at the meningococcal vaccine rates, they increased from 65% in June 2022 to 78% in March 2023. And this is getting closer to the rate of 86% achieved in the 2017-2018 pre-pandemic year. For hepatitis B vaccine and HPV vaccine, the SIP program involves another round of school-based clinics. These are currently underway to provide the second doses necessary to complete the vaccine series. If we can move to the next slide, please. Additional recovery work in the immunization program recognizes that Ontario's Immunization of Schools Pupils Act requires that students be vaccinated against 9 designated diseases or have a valid signed exemption form to attend school. You can see here that Toronto Public Health is notifying families by letter of missing doses so that they can submit up-to-date records and or catch up on missing vaccine doses. Routine childhood vaccines are traditionally administered by primary care practitioners. We know that access to primary care may be a barrier for many students seeking to update their routine vaccinations, and some may not even have a primary care provider, or others might have had difficulty accessing their provider during the pandemic. So while we are sending out these letters, we are also providing these routine childhood vaccine doses as a recovery measure at our mass immunization clinics. This enables students to stay up to date and facilitates improved coverage. Ultimately, if I can put it together, records assessment that notifies families of missing doses of routine childhood vaccines and access at our MICs helps protect the community from vaccine preventable diseases when that coverage increases. We're very pleased to see that there has been participation in these offerings, and since these childhood vaccines became available in our MICs in February of this year, 2023, we've administered over 2,000 doses. We can go to the next slide, please. So I know many of you are probably pleased that spring has begun to sprung. And we also have some recommendations from the National Advisory Committee on Immunization on COVID-19 doses. You can see them summarized here, and there is a strong focus on the highest risk, preventing them from getting sick from COVID-19. And the National Advisory Committee for Immunization was quite explicit that their goals were to minimize serious illness and death and societal disruption from the COVID-19 pandemic, and transition to a sustainable approach to long-term management for COVID-19. So these recommendations included considering the epidemiology of COVID-19 and thinking about who continues to be at highest risk for hospitalization and death from COVID in Canada. If you look at these specific recommended groups, such as those over the age of 65, Indigenous people age 55 and older, and their non-Indigenous household members 55 years and older, residents of long-term care and retirement homes, those with severe and moderately weakened immune systems, those living in congregate care settings for people with complex medical care needs, and those who did not get a booster after September 1st. Part of the rationale for this is that we do know a greater proportion of older adults have protection from vaccine only and have not been infected compared to younger ages. And we do have indications that hybrid immunity from vaccination and at least one COVID-19 infection may produce higher levels of protection and last longer. So we want to focus on providing boosters to those who need it most and have the most potential benefit from protection. If we could move to the next slide, please. We've heard in some of our presentations today about how public health really does have connections with the community and with the healthcare system to advance and promote health and reduce health inequities. And at the same time as we span the community and clinical care sectors, we also work within a wider system. Toronto Public Health is part of a provincial, national, and ultimately international system working to promote and protect health. And a demonstration of that is our work on adverse events following immunization. So you can see here that adverse events following immunization can be submitted by many different groups, and on the next slide I'll show you some details on that. And Toronto Public Health's role at the local level is to receive those reports, collate them. There is a team of specialized nurses as well as associate medical officers of health that can be consulted to review those records, which are ultimately submitted up to the provincial level. And people can access reports of adverse events following immunization and publicly funded vaccine in Ontario through Public Health Ontario, which releases summaries of those periodically. For example, in Ontario, there had been more than 37,450,000 doses of COVID-19 vaccines administered from December 13th, 2020 to March 26, 2023. And you can go on Public Health Ontario's website and take a look at that report, and any member of the public can access it. And you can see that from that summary, a little over 22,000 reports of adverse events following immunization were submitted on those over 37 million doses, and 94.5% of them were reports that did not require hospital admission. So this is a unique, important component of local public health work in receiving, collating, and initially assessing those adverse events following immunization to help monitor vaccine safety. That also involves actions by the national level and the global agencies such as the World Health Organization. So if we go to the next slide, please. This work is critical to monitor vaccine safety and ultimately maintain confidence in our immunization programs. And APHIS can be reported by health professionals, hospitals, local public health units, and by the general public. And in fact, in Ontario in 2019, almost a quarter of the adverse event following immunization reports on publicly funded vaccines were submitted by people who were experiencing the symptoms themselves or by their family members. Okay, if we can go to the next slide, please. I have an update on some developments from a request from our provincial colleague. If we can go to the next slide, please. Ontario's Chief Medical Officer of Health has requested that Toronto Public Health develop an approach to managing COVID-19 vaccine ordering, inventory management, and logistics and distribution capacity for the Toronto region. That would include immunizing providers of COVID-19, such as primary care, long-term care homes, retirement homes, and hospitals, but not including pharmacies. So currently, Toronto Public Health is enabling long-term care homes, retirement homes, and primary care providers to request and receive COVID-19 vaccines through the Ministry of Health's ordering and delivering systems. The difference from the request from the CMOH is that now we're going to have to assume oversight of the vaccine inventory and logistics for the region of Toronto. And it will now mean that the hospitals now come into these processes through us. So we've begun the first phase of implementation on this on April 1st. And this means that we began to review and approve all COVID-19 vaccine orders and inventory management processes for all hospitals and other providers in our region. The next phase of implementation is going to require significant, substantial logistical planning to secure space and systems to allocate, store, distribute, and deliver COVID-19 vaccine for all Toronto providers that administer it. And the target for that, given to us by the Ministry of Health, is July 1st, 2023. This does represent a significant new line of operations for Toronto Public Health. Previously, other non-COVID publicly funded vaccines in Toronto were organized and distributed by the provincial Ontario government pharmacy directly to immunizers, such as hospitals and primary care providers. There are over 1,500 immunizing agencies in Toronto. So for us to be able to begin to oversee these functions for COVID-19 vaccine in this region will be logistically complex and will require us to establish processes to assess and monitor vaccine inventory and distribute vaccine at a scale that is at least twice that of other health units. And as you're all familiar, this is a large city in terms of geography with high space and transportation costs. Other health units have had a role in vaccine storage and distribution for publicly funded vaccines and have been able to build their inventory management and distribution capacity over time. TPH will have to create this quickly to meet the request of the Chief Medical Officer of Health, and this has been outlined in a proposal and funding request to the Ministry of Health submitted in early April 2023. If we can go to the final slide, please. So in conclusion, I hope I've been able to share how public health actions have been resulting in vaccine coverage improvements. We have noted the particular needs of grade 9 and 10 students for the additional SIP catch-up opportunities that they require and have been, as I've described earlier, offering it to them. And our assessment of student records is also an important protection measure to protect the community from vaccine preventable diseases. Thank you.
Thank you so much for that, Dr. Lamptey. 1 second. Okay, let's get into some clarification. We do have one deputant here. I'm going to have her speak first, and then we'll come back to you, Dr. Lamptey. Is that okay?
Thank you.
We have one speaker to this item, Mariko Yude. You may go ahead. You have 5 minutes.
Toronto, And I'm here to depute on my concerns about the COVID-19 vaccinations that we're continuing to give them to all ages, including kids down to 6 months. Thank you to the speaker today on addressing adverse events following immunizations, AEFIs. They are real, and they aren't, well, they are rare. It depends on what your definition of rare is, but there are many people who have had adverse events following the COVID vaccination. And so that's why I'm here. And I wanted to quickly go over my 4 reasons, my logic for this. First, these vaccines are not like previous vaccines. They involve a lipid nanoparticle, which has never been used on this mass scale for vaccines. And also it includes the mRNA, which goes into the cell. And so it's a novel therapy, and the more novel a therapy, the more testing is required. And there was really rushed testing of these COVID vaccines. The preclinical testing is where you use animals and so on, and that's where you test the safety in detail. And that part was, it skipped a lot of processes. And then there was the clinical trials, which are the human trials, and those were cut at 6 months because after 6 months, the people in the control group were given the opportunity to take the vaccine, so then we lost the control group. So the most we have in terms of randomized control trial data is 6 months. And then we've had passive reporting systems like the USA's VAERS system. This stands for Vaccine Adverse Event Reporting System. And 2 months ago, I was here at the last meeting, and I reported that there's 16,000 deaths and 14,000 permanent disabilities possibly linked to the Pfizer and Moderna vaccines in the VAERS systems. Now, there are underreporting and overreporting problems, but of these, I believe many of them do have vaccine relations. And finally, there's been personal testimonies that have been pouring in. Currently in Canada, did you know that there's a citizen-led national citizens inquiry, and it's going across Canada, and it was in Toronto on March 30th to April 1st, and there's testimonies, and you can listen to them at nationalcitizensinquiry.ca. And the testimonies are a bit long, but if you are short on time, I highly recommend this US testimony, which is with the National Academy of Sciences, and each person there only has 3 minutes to talk. So it's in 15 minutes you can watch like 5 deputations, or actually it's listening. And you can find that by Googling National Academy's Review of Relevant Literature Regarding Adverse Events Associated with Vaccines meeting. And then that should bring you to the National Academy's website. So in summary, I don't believe these are safe because they weren't sufficiently tested. The vaccines are a novel type of vaccine, and the personal testimonies and the VAERS data. I also wanted to mention that in Switzerland, authorities are saying no COVID-19 vaccination is recommended for the spring of 2023. People at high risk can still receive a vaccination, but they have to get an individual consultation with their doctor first. So there are different countries taking different approaches currently. And I just wanted to say, in ending, that I have scientists and professors at universities in Canada that are willing to talk to people. So if anyone has any questions, I'm willing to organize a meeting. And finally, on the effectiveness of the vaccines, when I look at the Canadian data, they have data on COVID-19 cases based on vaccination status. And at the start of the pandemic, or start of the vaccine rollout, it looked like the unvaccinated were getting sick more. But then since about a year ago,
This graph shows that it's the fourth, like the people who have
You're at 5 minutes.
Okay. The fourth shot people are having more COVID-19 deaths.
Yeah, thank you for your presentation. Any questions for Deputant? Okay, seeing none, thank you so much for coming in today. So I do have a proposal for directors. We could finish with Dr. Lamptey and her presentation in regards to questions and speaking, and then we could take a 15-minute break, then come back and finish the agenda. Does that work for everybody? Okay. Okay, well, so yes, to be fair to others, we'll take a 15-minute break. Okay, so let's move that item. I'll move it. All those in favor? All those opposed? That's carried. Wonderful. So, Dr. Lamptey, thanks so much for being with us today. Any questions for the doctor? Go ahead, Director Roy.
Good afternoon. Thank you for the presentation. Just a quick question. I'm seeing the first chart that you showed. The immunization has started dropping significantly from 2018, 2019. Is that because that is pre-pandemic? So why such a huge drop 2018, 2019? Are we seeing more hesitation in schools even before pandemic?
Thank you, Director Roy, for the question. I don't actually know the answer to that, but I think one component could be just the fact that it is some of these vaccines are a 2-dose series, right? So even though we go in grade 7 and 8 to offer them, there still might be some children who miss perhaps 1 dose the first time we go in the middle school and then catch up in grade 8. If they were going into grade 8 as we're going into the pandemic year, then they just might have missed that extra catch-up opportunity. But I don't actually know, and we could perhaps come back with more specifics. Dr. Davila, do you have anything to add?
Yeah, so through the chair, I mean, the significant drop-off is really in the 2019-2020 school year, which was the first year that was actually impacted directly by COVID. You're going to get a little bit of variation here. I don't know that it's particularly well demonstrated on the graph, but really what the impact we're trying to show here is that of the pandemic. It disrupted in the middle of that school or academic year, and that's when you see the real drop-off in respect of uptake.
So now going back into in 2023, are we seeing any additional hesitancy for the regular HPV, meningitis, and hepatitis B vaccines? Is there a vaccine fatigue?
So through the chair, I think it is a little too early to say at this point in time. Certainly there have been questions raised around vaccine. There's been a lot of misinformation and frankly disinformation spread through a variety of different channels. I do think that what we're seeing is as we are able to make the school immunization program vaccination more available, we are starting to see the uptake and the coverage increase. But if I can, I would suggest that let's complete this school year and observe its early days yet. But please know that that is on our mind, and we are absolutely concerned with making sure that our young people are afforded opportunities to get these life-saving vaccines and, frankly, cancer-preventing vaccines.
Thank you. Any other questions? Dr. Thompson? Councilor Thompson?
Thank you, Mr. Chair. Through you to Dr. Lamptey. I'm just looking at the chart here on page 7, and it's titled the Canada's Vaccine Safety System Review. So there are a number of areas in which reviews the process in terms of vaccine prior to a vaccination program being implemented as such?
Yes. So this is showing you the surveillance system once a vaccine has been licensed and is being used in the community.
Right.
The system that monitors any reports of potential adverse events. But before we get to that stage, there are several series of scientific evaluations. Usually when a new pharmaceutical agent is being researched, They might first try animal studies. Then there are human studies that try and look for dosing indications, then for evidence of benefit and safety. And those are all reviews that are assessed by Health Canada before a product is licensed for use in Canada. So yes, you're correct that this is showing one component of the later stages of vaccine safety monitoring and assessment, but there are several that precede that.
So this would be after a particular vaccine has been approved and such?
Yes.
So this is monitoring throughout that ongoing process? So
Yes.
It's not just left in abeyance?
Precisely.
Right. So could I have an adverse reaction to aspirin?
Yes, sir.
Okay. So it's a possibility you can have an adverse reaction to many different things that have been tested.
Yes, absolutely, and that is why for all for all products used in humans, pharmaceutical products used in humans, whether they are medication taken orally or injected, vaccines are a preventive medicine that's often injected. We always talk about the risks and benefits of the intervention for that individual.
Right. And given the pandemic, and it's been discussed here this morning that, folks, Dr. Davila, prior to having vaccine, our situation was largely seen as if we were in a doomsday situation. Those are just my words, quite frankly, not necessarily scientific words. But my question, had we not developed some type of vaccine measures, would our particular conditions be different today? And I know lots of people died, and obviously the vaccine, has been said that the vaccine has helped a lot of people. I'm one of those. What then is the benefit of vaccination, whether or not it's for COVID or other types of disease, if you will?
So through you, Mr. Chair, I think what you're pointing out is the conditions of the pandemic a few years ago were very different than they are now, which means that the risk-benefit calculation for each individual in the population was different. Vaccines have allowed us to get to the stage where we can meet in a room like this safely, without fear that people might get infected and get serious harm from that infection. So vaccines absolutely change the risk-benefit calculation for the benefit of Toronto residents to allow us to start to resume our pre-pandemic activities safely.
Yeah, I was looking at the baseball game the other day and how the proximity people were so close, and in fact, going to a ball game has been a game changer by the vaccine. Would you agree?
Through you, Mr. Chair, yes, I would.
Right. And so when we look at the percentage, and I've done a quick calculation, I may be a little bit off, but it's sort of like 0.006% of, if you look, I believe your total was 37,450,000, and of that reported 22,000 people with respect to adverse effect and reaction?
Through you, Mr. Chair, yes. So it's been a small number of adverse events following immunizations for COVID-19 vaccines when you look at the total number of doses administered.
Would that be usual or unusual in terms of any types of vaccine or vaccination program, that you would have some adverse effect?
I think it's typical that for any publicly funded vaccine that you would have some adverse events following immunization reported. And you can actually look at the Public Health Ontario data to see the volume of those that have been submitted over the years. And that is because we expect with any medical intervention, there are going to be some risks and there are going to be some benefits. And the whole reason we have this system is to get signals, detect patterns that might indicate there's something we need to change. And I would see that because of this data, we see that reflected in the spring booster recommendations for COVID-19 vaccine this year. It's much more selective about who is recommended to receive it in terms of receiving the most benefit from protection, now that many of us have had several doses and many of us have also had exposure to infection. So I think there is a continuous connection between the quality of information we get from these reports and the quality of recommendations we make to the public on the use of vaccines to keep the public safe.
And it's not mandatory in terms of a boost. You're recommending that you get a boost. Is that correct?
Through you, Mr. Chair, yes, the recommendations are voluntary.
Right, so one has to consult perhaps with their doctors, family members, and you had a listing in terms of category, age, and other types of conditions, and one has to take that into consideration.
Through you, Mr. Chair, yes, absolutely. I would say now, at this point in the pandemic, it's much more of an individual assessment for the benefit of recommendation for any particular individual, because we've all had potentially different experiences with the number of doses, time since doses, and time since our last infection.
So lately I've been getting a lot of calls, lot being I think probably even the last 2 weeks from 7 or 8, from people saying, Councillor, you have to advocate against vaccines and whether or not they're mandatory or suggested that you get them. What would you advise me to do?
So through you, Mr. Chair, I would encourage you to point people to the recommendations, which are voluntary and which are very specific about who's recommended to get doses at this time. And they are voluntary, so I'm not sure that there is any need to advocate for them to be voluntary because they are.
Thank you very much for that. Thank you, Mr. Chair. Those are my questions.
Thank you. Any other directors want to speak? Okay, no, seeing none. I just have 1 or 2 questions. Just to clarify, the HPV uptake is at 66% as of 2023. Do students in grades 7 to 9, do they have to opt in or opt out of that? You may have mentioned it, I missed it.
Through you, Mr. Chair, for HPV vaccine, it is a voluntary vaccine, although it is strongly recommended for the students we offer it to. And I do note that the 66% is at this point in the year when we have not completed or only just begun our second round of visits for the second dose. So we really have to give the program time to have that second set of visits to really assess where we are in terms of coverage. But yes, it is recommended.
Okay, thank you. Just one final question. So I read last week that Canada has 19 million doses of vaccine in storage, and that's going to be expired before the end of the year. How much do we have in our arsenal here in Toronto, and when is the expiry date for those? And if they are up for expiry, what are we going to do with them?
Through you, Mr. Chair, I'm going to ask you directly. So are you referring to COVID-19 vaccine?
Yes, I am.
Okay, so I don't have my fingertips right now at the amount of doses we have in our inventory. However, part of our role in assuming the oversight of inventory for the region is to strategically assess the orders coming in to make sure we don't order more than we feel we can use. And we do know we're trying to be responsible stewards of that. It is a publicly funded resource, and we do know that it has a shelf life. So that all goes into our inventory assessment and ordering placement, not just for us now as TPH, but now for all COVID-19 vaccine providers in Toronto. In terms of expiry, we do work with the ministry in that they have regular calls where upcoming expiry dates are reviewed with health units so that people can assist each other if there's imbalances, so that we don't get to the point where we have product that's wasted. There are also communications between the provincial government and the federal government when evidence becomes available that potentially the shelf life is longer than first thought. In terms of actual use of any product that can't be used, if it can't be used, it then becomes something that gets returned to the province. And there have been many discussions about what can occur with that product, but often it can't be used, it has to be destroyed.
Okay, thank you. Any speakers on this item? Seeing none, okay. May I have a motion to receive this? Well, someone needs to move it. Director Chandra, you want to speak to it, or you want to move it? Okay, Director Chandra Balen. All those in favor? All those opposed? That's carried. Thank you so much. We'll take a 15-minute break. We will come back for, let's say, 1 o'clock, 1:05. Yeah. Put it in here. You have to put it in. Oh, she was small. One job.
Do you see how he treats me?
You have one job.
I succeeded.
Are we on?
You've got 7 in the room, so you've got 4, and there's also 2 still on, if, I don't know if you want to check if they're there.
That's okay. Okay. All righty, we have quorum and we'll resume. Thank you, everyone. I hope everyone had a chance to refresh for 15 minutes. So next item is HL 3.3, final report from Black Scientist Task Force on Vaccine Equity. The co-chairs of the Black Scientist Task Force have been invited by the Executive Director, Social Development Finance and Administration Division, to make a presentation on their recent work with Black communities on vaccine equity, along with lessons learned from the pandemic and the early stages of recovery. And before they do start, I'd like to make a comment. The task force was awarded the City Manager's Award for Equity, Diversity, and Inclusion last Wednesday, so congrats to you. Awesome. So you may begin your presentation. I'm not sure if, do you want to introduce them? Okay, awesome. Okay. Does the clerk have the slides, or does anyone who has the slides?
Okay, no.
Or you can do it yourself if you wish.
Yeah, right there. Okay, while we try to set up the slides, I just wanted to make an introductory point for my colleagues on the task force. My name is Akwatu Kenti, and I was oh, there it is. Thank you so much. This initiative, a Black Scientist Task Force on Vaccine Equity, was the first of its kind in Toronto, Ontario, and Canada. Forged during the most critical moments of pandemic-inspired doubt and disaster, amidst a surge in speculations that undermine vaccination uptake and COVID help seeking, the Black Scientist Task Force dispelled wide-ranging misinformation, disinformation, and racial stigmatization. Not only did it shine light upon the deep and persistent sources of vaccine hesitancy and mistrust, it added a voice to public policy making that is seldom drawn upon and accorded a place at science tables, that of Black scientific expertise married to a wide range of lived experiences. I wanted to introduce the co-chairs and the task force to say a thank you, because the 12 members of the task force have served what was supposed to be 6 months, then 12 months, then 18 months. It turned out to be 2 years and 4 months. And so I really wanted to acknowledge their incredible public contribution to the City of Toronto in general and to Black communities in particular. Take it over.
Thank you. Next slide, please. On behalf of the Black Scientist Task Force on Vaccine Equity, I'd like to thank you for having us here today to landmark the work of this incredible team. A special thanks to Toronto Public Health, the City of Toronto's Social Development, Finance, and Administration team, Taibu Community Health Center, this great collaboration for a truly authentic collaboration on this project. Next slide, please. Formed by a strong caliber of Black scientists across a variety of disciplines, the Black Scientist Task Force on Vaccine Equity was born out of the urgent need to mitigate health disparities in one of Toronto's most vulnerable populations during the COVID pandemic. Where Toronto's Black community accounted for about 9% of the total population, this community was overrepresented when it came to COVID infections, hospitalizations, and death, with rates at nearly 30 times, with rates at the time of over 30%. We knew this because of the race-based data that was collected at the beginning of the pandemic. This data was crucial in saving lives. Next slide. So listed on the slide as a lot of our accomplishments. This task force has had great success in moving the dial with respect to vaccine uptake and addressing vaccine hesitancy in the Black community, as well as providing a safe space for Black community members to speak about and get educated on their health. But what's been even more incredible has been the reach and the engagement of this task force. Through media, fireside chats, virtual town halls, social media, and community events, we've been able to reach every sector that touched Black communities. Black community members from African and Caribbean roots, Francophones, Portuguese-speaking Blacks. We've collaborated with Christian and Muslim faith-based groups, the LGBTQ community, farm workers, seniors, city workers. We've also supported efforts beyond Toronto in Waterloo and Peel, a feat that is truly one of a kind in Toronto, in Ontario, and in Canada. Next slide, please. Although the work done by this task force has been tremendous, there's still work to be done. COVID-19 was not the beginning of health disparities in Toronto's Black communities. The pandemic merely shone a light on the gross health inequities faced by Black community members. From chronic disease to mental health, if we want to avert another crisis and protect Black health, these disparities need to be addressed. Of note, and through the work of the Wellesley Institute, including Dr. Kwame McKenzie, a member of a Black Scientist Task Force, there's new evidence showing that Black people now make up 30% of the homeless population, a statistic that certainly needs attention. Next slide.
Okay, thanks, Candice. I'm going to talk about some of the lessons that we learned and the disproportionate impact of COVID on the Black community was caused by various systemic barriers. And the strategies and actions to address these barriers and to provide access to high quality services must be informed by data. And in the early phases of the pandemic, there was race-based data available, especially from the Toronto Public Health Organization, amongst others, that was really critical in highlighting the disproportionate rate of COVID cases and the high level of vaccine hesitancy within the Black community. And of course, this led to the creation of this task force and initiatives to serve the Black community specifically. Unfortunately, data at the same level of detail and granularity was not available for monitoring the levels of vaccine uptake in the Black community specifically. There were inferences from the number of COVID cases in different postal codes within the GTA, and combined with pre-pandemic census data, suggested that many districts with the highest percentage of Blacks had the lowest vaccine uptake. So this was information that enabled these areas to be targeted with pop-up clinics, information sessions that really helped to bring the levels of first and second dose vaccination uptake on par with the general population. And of course, this would result in reduction of serious illness, hospitalization, and death in the Black community. And of course, if race-based data, health data was routinely collected, or if collected, analyzed in Toronto, we would have had a more precise knowledge of where to focus the services and resources during the pandemic. And maybe we could have seen an even better and earlier improvement in the health outcomes in the Black population in the GTA. And clearly, consistent collection of race-based data will better prepare us to target the resources and services to vulnerable communities in future pandemics and for ongoing chronic health conditions. Next slide, please. But we also found and we realized that access to services and information alone is not sufficient. And the willingness of vulnerable communities to use these services and to respond positively to information is also highly dependent upon who is providing the service and giving the information. And we think that successful outcomes from our work and the work of other community members were achieved during the pandemic because of the critical role that the Black community organizations played in sharing information and providing the services. And the subject matter experts on the task force and in our partner organizations really became a trusted source of information for the community because we were able to dialogue and provide services in a culturally sensitive manner. And we think that this proven health service model needs to be practiced for all targeted outreach and health education programs for the Black community. Next slide, please. So we have a number of recommendations, really based on our experience, the observations, and the customer feedback over the last 2 years of outreach and health education in our community. And we propose the following sort of forward-looking recommendations to this Board of Health. Firstly, the inclusion of community-led research on Black health in epidemiologic reports. We need to continue to take advantage of the expertise within the Black community organizations and the improved engagement of the community at large, because this will reinforce the message that we as a city care about improving the health and well-being of Black Torontonians. Also, we think that the Board of Health should recognize equity-based race data collection as being demonstrably crucial to understanding the pandemic's impact on Black communities, being able to identify areas of need and creating targeted interventions and policies. And Toronto has been a leader in this approach, and we're asking that Toronto continue to exercise leadership in this regard with respect to the general health issues in the Black community, not just during pandemic times, but throughout the years where general health in that community is really a problem for many people. And while we may have passed the worst of the pandemic, the effects of COVID-19 are still persistent. Long COVID is an ongoing problem, persisting sometimes beyond 6 months, in up to, they say, 20% of infected persons. And we can assume that long COVID is impacting the Black community at a disproportionately higher rate, just as COVID infections did. Also, as we've heard already this morning, there's an increase in experiencing and reporting of mental health issues since COVID, especially in terms of anxiety and post-traumatic stress. And we know that Black mental health has traditionally been overlooked and under-resourced. So we're proposing that the Board of Health recommend to the Council that the City continues to address long-term health outcomes of COVID-19 for Black Torontonians, especially long COVID and mental health. Next slide, please. And in closing, we hope that we've been able to demonstrate from this report of the more than 2 years of work of the task force that race and health equity is efficient and effective. Thank you.
And if I could say one thing, because I didn't introduce my colleagues, we just jumped right in.
Sorry about that. Go ahead.
So, Dr. David Burt, he's an immunologist and actually an inventor of vaccines and formerly a senior executive in a vaccine company. And Dr. Candice Stodd, a naturopathic doctor.
Thank you for that very informative presentation. Much appreciated. Due to sort of our procedure, we do have a deputant to speak on this item. So if you don't mind, just thank you. And then we'll invite you back shortly after. So we do have Ken Knoll, President of the Walnut Foundation, and Anthony Henry, First Vice President of the Walnut Foundation. So between the two of you, if you're presenting together, you do have 10 minutes.
Okay. While Ken is getting the systems up, I just want to say, having a resource like the Black Scientists Task Force to pull on was crucial during COVID. Even our focus is prostate cancer. But when the misinformation started swirling around, it was good to have that resource to draw on. Thank you.
So you have 10 minutes, and I'll start the clock when you start your presentation.
Sure. So thank you, Chairman Chris, for inviting us. We really do appreciate this opportunity to do this. So we're going to start off by a short video that positions where we are regarding a very important topic of prostate cancer.
I think we need sound. Our tech person is coming. Pause the clock.
Try now. Thank you.
You have prostate cancer. How could that be? Every day in Canada, 63 men are diagnosed and 11 men die from prostate cancer. A man is more likely to develop prostate cancer than he is colon, kidney, melanoma, or stomach cancers combined. Something else to be aware of is that breast and prostate cancer can co-occur in families. Women with a family history of prostate cancer are at an increased risk of breast cancer. A recent study reported that prostate cancer accounts for 18 to 47% of cancer deaths, and men who are of West African or Caribbean descent have a 76% higher rate of prostate cancer and are 2.2 times more likely to die from it. If it's detected late, the survival rate in 5 years drops from nearly 100% to only 30%. A scary thought. A national survey found that many Black respondents weren't even aware that they could be at a higher risk of developing the disease, and many are at risk of being undertreated because of inequalities in the health system. If you're a Black man over 40, listen up. Your life matters.
So, my name is Anthony Henry. I'm a prostate cancer survivor, and I'm first vice president at the Walnut Foundation. My father died at age 68 due to a late-stage diagnosis of prostate cancer. Why? He was not screened early enough. Since blaming or suing could not bring Dad back, my family and I set out to educate ourselves.
Your video, I think, is probably still on. Maybe.
I continue.
Go ahead.
Okay. As I was saying, since blaming or suing could not bring that back, my family and I set out to educate ourselves about this disease. My brother and I started screening via the PSA blood test and a digital exam at age 40. Both of us went on to catch cancer in a timely manner. Myself at age 54, and my brother at age 57. We also have an uncle on my dad's side whose cancer was caught and treated in a timely manner. A challenge for men is that intervention often means incontinence and erectile dysfunction in varying degrees. However, we have the medical knowledge to deal with these issues. There is life, good quality of life, post-diagnosis. Screening does work. Education and awareness is critical for those most vulnerable segments of our population. Silence serves no one. So Ken will continue with some stats.
So thank you, Anthony. So in the video, it referred to men of West African and Caribbean descent having the highest incident. One sec. So the WHO published statistics in 2020, and as you can see, the top 10 countries with the highest mortality from prostate cancer were in West Africa and the Caribbean. Places like Barbados, the second highest per capita death rate. So when you look at Canada, most of our black immigration comes from countries in West Africa and the Caribbean. So Anthony and myself partnered with Dr. Aisha Lofters, who is a black scientist from the University of Toronto, to do a study in Ontario based on immigrant data of men immigrating to Canada, because in Ontario we do not keep race, or in Canada we don't keep race-based data. So what that data revealed, and this has been published in this Canadian Medical Association Journal Open, the top line are men of West African descent, and the second line in that chart is men of Caribbean descent. So this mirrors what the WHO was saying, that men of West African and Caribbean descent have the highest incidence of prostate cancer. Now, you're going to ask, what are the reasons? So potential reasons, and we looked at US data and we looked at UK data as well, because those countries do keep race-based data. So, you know, science hasn't specifically said what, but then we looked at things like social disparities, economic disparities, genetics associated with being of West African ancestry, because most of the slave trade was done through West Africa. Environmental factors, dietary factors, access to equity in healthcare. So there was a lot of factors that need to be addressed in future research projects. So a little bit about us. So we're a 100% volunteer-based registered nonprofit. Our mission really is to bring awareness to the Black community. And we do this through education, monthly meetings. We go to churches, we go to community groups, and we educate Black men to get themselves checked early. So the other thing that we do, and we're the only one in Canada to do this, we provide a safe and confidential support group where we invite Black men who've been diagnosed, who are being treated, to actually meet in a safe and confidential environment to share things. One of the other big things that we've been doing, we're partnering in research. The Walnut Foundation is a go-to organization from a lot of the hospitals to partner in research into prostate cancer around Black men. So right now we're involved in 2 research studies with Princess Margaret. One is looking at genetics, and the other one we're looking at cancer care among older racialized adults in Canada. We're working with the Canadian Cancer Society looking at equities in cancer care among prostate cancer in Black men in Canada. We're going right across Canada for this. And then we partnered with Movember on looking at telehealth care in the Black community as well. One of the important things that we started to do last year is that we seeded an endowment with the Temerity Faculty of Education at the University of Toronto to actually give merit awards to Black medical students going into the Faculty of Medicine. A lot of the men that we deal with tell us that when they go into hospitals and cancer care centers, they don't see us. They don't see a lot of Black people. So we're trying to change that system by seeding scholarships, and we're going to be doing the same thing with the Toronto Metropolitan University medical campus that's going to be done soon. So how we do this, all our funding comes from our annual walkathon, which is going to be in June this year. We're 100% volunteers, so we have no staff, so all our funding go onto services. But our challenge, so we're the only organization that we know of providing this awareness education. We're 100% volunteer-based. Some of us got our own businesses, but we spend an extra 40 hours a week doing this. But this model of operation is not really sustainable in the future. So we need help to transform our operating model in order to continue to serve the Black community. So our recommendation is that Toronto Board of Health partner with the Walnut Foundation to get the awareness message into the Black communities through its public health agencies. I think we should build on the strategy of the COVID-19 response strategy. That has been excellent, has worked very well, and I think there's an opportunity to build on that. Also, we need assistance to help to transform the organization. We have to move away from being 100% volunteer into a different organization, and we're prepared to do that through our last strategic plans. So I'm going to stop there and be open for questions.
Thank you very much for coming in and depute today, and it's nice to see you again. Any questions for the deputants? Councillor Thompson?
Yes, thank you. Through you, Mr. Chair. Thank you both for your presentation. Obviously, I'm one of those guys who's at risk, right? And so my question to you is that the province sends out a letter periodically for testing of prostate. Is that correct? Are you aware of that? They don't send anything out?
They do it for breast cancer.
Colon.
Is it colon? Okay. So what's the difference between colon and prostate cancer?
So if we can,
and why do you, no, I understand that, now, but why do you think that the province would play more emphasis on one and not the other, since it does have a significant impact, particularly on, as you pointed out, the Black population?
So we're not too sure why the province places more emphasis. We've tried to get some focus around prostate cancer.
Yeah.
Province, but we haven't been successful as yet.
Yet, okay.
The thing about prostate cancer, and the reason why men shy away from this is it affects below the waist.
Yes.
And so it affects your sexual health. So right away you start talking about the impact to the sexual health, and people shy away from it.
So education is a key part of this process, you think?
Education.
And
education, getting people to get to their doctors, get themselves checked as early as possible.
Right. So let's assume, for example, you had a permanent entity like the Black Scientific Task Force, and this being one of the issues that they're advocating and creating that advocacy and awareness and so on. Do you believe that it would be helpful to have such an entity that would be full-time basis? Not, it doesn't delineate or differ from what your organization is doing. In fact, it strengthens it by creating that large number of advocacy focusing on health and well-being. Do you believe that such an entity should be a full-time?
So with our organization, people come to us.
Yes.
The churches would call us to do a presentation. I think we need to change that model around where we're actually pushing it out.
Right.
And then you will see the differences. There's a lot of studies done in the United States where it's a big focus. Where going into the communities actually worked. Because it's not only about getting them tested, they're looking at their health, eating habits.
Right.
obesity, dealing with those types of things that all contribute. So it's the push out to the communities that are making a big difference.
Right, and so what I wanted just to validate from your perspective is I have a motion that I'm going to move regarding the Black Secretariat Task Force being a permanent entity. Do you think that having such an entity, as we've seen how they have benefited us through COVID, would be helpful to the Black community in general? And of course, prostate and other types of cancer and other health-related issues, subject and discussion and focus mental health. Do you think that this would be helpful to the community?
Absolutely.
I don't know if your microphone's on.
Of course, definitely. Anything that, you see, we are volunteer-based.
Yes.
A lot of the men in the group are men who've had, similar to myself,
yes,
who've had similar experiences. So we're coming at it from a patient perspective. It certainly would help to have that credibility factor and that more of that expertise factor on there. So for sure.
Right, okay. Thank you very much for that.
Thank you.
Well, Mr. Chair, I did have a question for the doctors. I'm just wondering if they would come back after.
Oh, they will.
Okay, great.
These are deputants.
Okay, no, okay, that's fine.
Thank you. Dr. Zhao?
Great, thank you, Mr. Chair. So my question, it's not so much of a question, but maybe a suggestion. In your research, do you look at what percentage of your study population have access to family doctors? Because currently, a lot of the barriers behind why individuals are not getting PSA testing is because they don't have access to a family doctor. And second to that is a lot of family doctors do follow the Canadian Preventative Task Force guidelines on prostate screening, which do not recommend screening for men over 55, but they do for colon cancer for men over 50, for instance. And that might be an area where you can kind of look at changing that in order to implement, certain guidelines based on the race-based data that you collected.
There are different facets to this issue. Part of the issue is how the medical professional sees the issue. For example, currently the standard of care suggests that the general population get tested at age 50. Our recommendations, and a lot of experts agree with us, that for our population, because of the higher risk, that we start testing at age 40. But just recently, there's a young gentleman that came to us, right? And he had gone the second time now to his doctor, asking for this PSA test that I just said to you saved me and my brother and my uncle. And he was told to wait until he's 50. He's 48. So there's a disconnect, certainly a problem. And so I think the message that we're trying to push out needs more help, more resonance. And I think this committee can help with that.
Okay. Thank you so much for coming out today. We appreciate you coming in.
Thank you. Thanks for having us.
Yes. We'll have our task force back. Thank you. So any questions from the members? Any questions for the task force? Councilor Thompson, go ahead.
Thank you very much, and good afternoon, and thank you all for the work that you've done. It has been very enlightening and obviously helpful, and I'm sure you've saved a lot of lives and create that awareness. My question to you, and recognizing that this is a volunteer position, is it volunteer, or do you get compensated any sort of remuneration at all?
Only a few, not all, but for the town halls, actually.
Just going to a town hall, you get compensated for your time?
Yeah.
but your expertise, your input and so on, that's all
No,
voluntary.
there's no salaried positions.
Right, and it's been proven to be effective to create awareness, reduce some of the stigma. You've got greater reach because of your stakeholder collaboration and so on. So if we were now just to look at this successful entity that has helped us through COVID and just to say, thank you very much, do you think that it would be better for us to establish or explore establishing something on a permanent basis, given the fact of the inequities that we talk about, given the fact of the challenges, the microaggression, all the racism and everything else that permeates on a daily basis for, and I'll just speak specifically to the Black community, do you think that this would be an entity that would be helpful to get beyond simply some of these day-to-day disadvantageous inequality that exists within the community to create better health options and opportunities for the community, which would be beneficial to everyone?
That's the opinion of the Black Health Alliance and the Black Health Working Group for Ontario, because they both asked the BSTF, the Black Scientist Task Force, to keep going and to continue, because they believe that the BSTF has been a significant resource. So that's a perspective shared by Black health advocates.
Right, and so issues like race-based data and its importance, this would form and underline an ongoing perspective, advocacy to achieve that that notion and that desire to get the province, for example, to agree in terms of moving forward. Would you agree that that would be helpful?
Absolutely. As a matter of fact, the task force had a session on race-based data for the International Day for the Elimination of Racial Discrimination, at which there were several MPPs attending. Right. And the point was made that it's hard to go back.
Right.
How could we go back on race-based data when race-based data has shown its equity purpose and it's been so crucial to saving lives?
Right.
Here we are having to argue for race-based data in health.
Right. So in 2020, and when I think it's probably about in March, when I had heard about some of the issues that were taking place in the U.S., particularly that's what I'd heard in first, where it was clotting that was taking place within Black Americans, and subsequently we heard about it here with Black Torontonians. I approached the Premier and Dr. Smith about this, and part of that they had indicated we asked for that to be done. It was obviously done. Was it an important element for us to collect some of the data? And I had also talked to Dr. Davila as well as part of our conversation. But was it beneficial to have that information? Absolutely. Based on collecting the data to help to form position and looking at how we invest in health outcomes and benefits to the community?
Absolutely. And just to give you an idea of how misinformation goes, one of the misinformations that was circulating across Black communities was that COVID doesn't affect Black people the same way. And so that was a perception, that was a myth, and the data just destroyed that myth instantaneously.
Right. So when we talk about, in particular COVID, and so vaccines, for example, I was at the JCA, I got my first vaccine shot at the JCA, Jamaican Canadian Association. There were many people in line. There were whites, Blacks, and everyone else. The service was not just limited to Blacks. It was available to who wanted to come. So my question to you is that in as much as we want to focus on the Black community, it isn't that we're actually opposed to others benefiting from services that would be geared towards the Black community in specific areas of the city where you have an aggregation of people living in the area. So people would have more exposure, would be of greater benefit to everyone, including the Black focus interests. Would you agree?
Absolutely. We take a...
No, I was just saying, I was just thinking, for instance, in a pandemic, the idea of vaccination, one of the ideas is to protect the community. So it's important to have that sort of overflow awareness outside of a particular community that is going to impact and benefit the whole community. And I think having, for instance, pop-up clinics at the Jamaican Community Center in the location where it is, you're going to capture a certain demographic, but we know that there are other cultural groups, ethnicities living in those areas, and they benefit as well, because we did see a wide variety of different cultures turning up. So I think in terms of the population level, it's really I mean I think if you unless you protect everyone, then you're going to be at risk for a pandemic perpetuating. So I think it's important, but it's also important to make sure that the group that is most hesitant and most vulnerable because of many different reasons is targeted in terms of putting resources and infrastructure in.
Thank you. Okay, thank you. Thank you. Any other counselor? Director Ozudi.
Thank you so much for the work that you've been doing, and health equity is really near and dear to my heart. So I really appreciate all the work that you all have done, collecting all this data and all the town halls and being out there in the community, boots on the ground. As much as this work is important to the work that the city is doing, the Board of Health, we know that health and healthcare is provincially funded in the city, and so as you're engaging the Board of Health and in that sense Toronto Public Health and the city, are you also engaging the provincial government and perhaps even the federal government so that they're also aware about this for this important work?
I wouldn't use the word engage, but we invited them to our sessions, recognizing that the complexity of the jurisdictional issues. So, for instance, when we had the race data session, we invited province, federal people to come attend, and several provincial people did attend. So, but we haven't set out to sort of advocate. That's not our mandate.
And what has been their response to that?
They came.
Okay.
We were surprised at the significant amount of people who attended, including the minister.
Okay, thank you. And my second question is, obviously part of the reasons why there is such a low vaccine uptake in the Black communities, it is multifaceted. It is also historical. I'm thinking about things like the Tuskegee experiment, right? There's also a role for, like social determinants of health, race, income, poverty, and all that. All those confluence of factors will then manifest as a lack of trust in institutions, right? And delay, treatment seeking or even engaging with established, community health centers, hospitals, etc. What did the report say about trust? And for those of us who are on the Board of Health, what advice would you have for us to build trust with the Black communities?
Candice, you want to take that one?
Sure. So, absolutely, we did see that historical mistrust was a big issue with the community.
So is your mic on?
The light is on.
Okay, thank you. Okay.
Can you hear me?
Yeah? You have to go closer.
Can't.
Yeah, just project it. Yeah.
So, absolutely, one of our, you can hear me. One of the keys at the beginning, when we started to introduce these town halls, was the historical mistrust that exists in the community. It's something that we addressed right from the beginning. And it was important for us to engage with the community and have representation from people that look like the community. So I think that was a big way that we were able to build that trust and bridge the gap that was existing with, help seeking in this community. So it was a big part of even the initial stages of implementing the work that we did.
And could I say very quickly that we didn't try to earn trust, because trust takes time to earn and it's easy to lose. What we tried to do was tell people, you need to be able to make a balanced decision, whatever your leanings are. And you need to be able to weigh the evidence. And here's the basic knowledge set that you need to weigh the evidence. Vaccine preparation, trials, number of adverse events, what the science says about recovery, treatment, life saved, pregnancy, not pregnancy, all of that stuff. How do you weigh that when it's coming at you? So that's really the concentration. Concentration was on literacy to be able to make the right decision as opposed to earning trust, because we realized this takes time. And even for people, who's, science, they got titles and all that kind of thing, people are suspicious of that as well. So really, the effort was to share information as quickly as possible and as effectively as possible.
And I think the beauty of the task force was that we had individuals who represented, for instance, in terms of vaccine development, people who were involved in manufacturing vaccines, testing vaccines, individuals who were at the other end of the spectrum where they're delivering vaccines and they know about, rare adverse events. So we could talk to the community with some degree of knowledge about what happens, how you develop a vaccine, the benefits versus the risks. And as Candice says, because we were from that community, I think we were trusted, and our role was just to give accurate information, because there's a lot of inaccurate information going around on social media. And our community is quite close-knit, and information travels rapidly. And it was important, in terms of, bisecting a lot of those routes with information and challenging our community to do fact-checking and check what we say versus what they read or what they see on videos.
Okay. The last point, which I think speaks to the earlier question very quickly, at long-term care facilities where we were able to sort of track vaccine uptake, the vaccine uptake didn't just occur amongst Black staff, but other staff. And that was very important. Other racialized staff, as well as non-racialized staff who came to the sessions, some of whom not voluntarily, because in some of the institutions it was mandated, but vaccine uptake was diverse. Not just the Black staff increased, but other non-Blacks as well. So there is a benefit for other groups, not just for Blacks.
Thank you. Not seeing any other directors wanting to speak, I will ask a few questions. So you mentioned in your presentation 30% of homeless population, 30% of the homeless population are Black in Toronto. How did your task force engage those groups? And also, too, has that number stabilized? Has it gone down? Has it gone up over the last couple of years? Do you know?
Well, it's been growing because of eviction and challenges getting rented accommodation. So it's just been tracking upwards. But we participated in sessions that were jointly held by SSAJ. That's how we try to reach out to the homeless populations as well.
Okay, thank you for that. And also, too, initially during this pandemic, it was hard for public health to engage Black people and other BIPOC people in Toronto. And so they created these community groups. I forget what they're called now. The vaccine engagement team, yes. So based on conversations I have with Dr. Davila, that is based because of funding, that is actually coming to an end. So I feel that, you know, with all the institutional knowledge we've gained from that, that could be used to engage those same people in other ways. But, you know, that may not happen. So what are your thoughts about that? How would that impact your work, I guess, going forward?
Yeah, the evidence is clear. Vaccine ambassadors, earlier term outreach workers, community health workers work. They make a difference. In time, technology, transportation, addressing the key barriers, access issues that are interpreted as personal choice. Often, when you engage with those people who, for lack of decision-making, don't seek help, don't seek vaccines, you can actually convince them to get help, to get tested. And that's what the ambassadors did. That's a significant accomplishment of the ambassadors that makes the ambassadors a model to continue, as well as just, you know, wave that flag everywhere for other jurisdictions, because it worked. Yeah. Now, you know, this is very different from school. In school, you get the lesson first and then the test. But in the pandemic, we got the test first, and now we're drawing lessons from the test. And the lessons, one of the biggest lessons is that outreach to vulnerable and marginalized groups works to benefit their health.
And I think the interest for some iteration of the task force going forward for other Black-focused health issues was expressed from the community. We've had a number of events. For instance, in January we had a summit, a health wellness summit, where we did focus on COVID, but we covered a number of other issues like prostate cancer, breast cancer, diabetes. We had a very large number of groups representing, you know, health areas that really impact the Black community, and the members of the community who attended wanted to know, well, because we sort of did it in a way that we thought it was sort of the end of the Black Scientist Task Force, and when they heard that, they said, well, how can you stop? I mean, all these other issues are there. I mean, we need something like this to continue. So it's something that I think the community at large is expecting in some iteration, not only from, you know, community leaders, but from actually community members themselves.
Thank you very much, and those are my questions. And seeing no other questions, thank you for your presentation and for coming in today, and thank you for all your work, your hard work for the last couple of years on this. It's much appreciated.
Thank you.
Yep, so now we're going to go to speakers. Councillor Thompson. Okay, sure. Yeah, sure, if they want to stay, not a problem. So
closer to be able to seeing them. As opposed to, there's a column there. I can't see around the column, regrettably.
Fair enough. Councillor Thompson to speak.
Thank you very much, Mr. Chair. I have a motion that I'd like to ask staff to put that up. The motion reads as follows: that request a medical officer of health to explore the establishment of a permanent Black Secretariat task force to address any ongoing challenges faced by the Black community in mental health, cancer, and other health-related issues. And the word says any, but we know there are many issues and challenges facing the Black community. I want to, first of all, thank the doctors, Dr. Kente, Bert, and Todd for being here with us. But I also want to thank our special secret agent, Ms. Denise Andrea Campbell.
Oh, yes.
An agent of change. And of course, Dr. Davila with respect to her leadership and so on. And you, Mr. Chair, and others, former Chair Cressy and others, and the Mayor Tory and others for seeing that this entity comes together. It's time. And if not now, when? We've heard that members of the community have asked for this. Why? Because it's actually important to them. We have heard as well, this is an award-winning entity that has come through COVID. So when I was chair of the Economic Development Committee, we put a task force together of business leaders and so on, and it was the emphasis of building back better, building back stronger. Because we identified that because of the shining of the lens on as a result of COVID, and so many things, there were so many challenges. This is one of those examples with respect to needing to recognize that there was an issue, and the lens of COVID, the lights of COVID, albeit as negative as it was, we've seen, initiative that has come out that has great benefit, great properties that have helped us. And so to suggest that this is the final report, when I read that, I thought that's alarming, quite frankly, because really this is just the beginning. Because we know the problem that exists is ongoing. And all of us here actually care, in spite of all the challenges and so on. So we have Black doctors and Black leaders who are educated professionals who actually understand the cultural differences and norms and are respected and appreciated. I went to the JCA to get one of my shots because I actually wanted to experience it. Went in line and go through the whole process. In line, there's a variety of people. Not all of them were Black, but they had been acculturated to this new information about the vaccine, and it had dispelled a lot of the fears and concerns that they had because they had been provided with information. It's been mentioned about Tuskegee and what has happened many years ago. Many of us weren't even born at that time, but we've learned through history the challenges, and it still exists. In fact, I'd heard one French doctor saying that we should test all the Blacks in Africa and give them all the bad drugs and see how it affects them. So there are people who have that view, none in this room and perhaps none in this city, and maybe there's one, I don't know. But the point is this, we have an entity that has worked. We've all agreed that we need to have that reach. We've all agreed that it's beneficial, and this notion that he who feels it the most knows it the best. I didn't coin that, but it's from Bob Marley, who has that view, and I fully agree with him. So what we need to understand that we will all benefit from having an entity that speaks to address issues around cancer, prostate, and you name it that affects the Black community. I think that over time, we establish this entity, and Dr. Davila is going to have with her team of doctors and others the ability to kind of frame and put something together, because it has to be funded, has to be budgeted, because if we take care of the community, it's going to be less burden on the system overall. And I don't know what those numbers are, but I can dare say that the numbers would be grossly beneficial to us in the sense that we'd probably have less people having the need and experiences to go to the hospitals and are in need of medical services and so on, because their awareness would be better off, their lifestyle and benefits and so on would be greater for them, and that would be a winning situation for all of us. So to that, I think as we have an award-winning entity, that we don't simply ban it and say COVID is over. In fact, we have received the benefits as a result of COVID, that we have an entity that can work and help us. So I would think that we really need to strengthen this and structure it in a way that helps us in a much more advanced way, as well as in terms of the advocacy to the Premier and the other doctors who will make decision on collecting race-based data, because it's important to us, because then we know and decide where we put our investments and so on. So, Mr. Chair, that's my motion. I'm hoping that members can support it, and I will ask for a recorded vote, Mr. Chair.
Okay, thank you, Councillor Thompson. Next on the list is Councillor Brown.
I just want to thank you for the work that you've done, the leadership that you've shown, and I think it just exemplifies how the deep relationships, the credibility, and the trust that you've brought allows for public health to deliver on priorities. I think it's a proven model, as has been said. In 2020, this board declared anti-Black racism a public health emergency, a public health crisis, and I think that we need to act like it. I also want to say that, you know, I'm from Latin America. Latin American people are indigenous. Latin American people are Black. People from, when you do your work, you lift everybody up. You lift the floor for everyone. If we can make the world better for Black people, we will all benefit, and so I think that's really powerful. I think also we had a discussion earlier about developing a mental health strategy, and I was very gratified to see in your recommendations that you want to ensure that any mental health strategy has that lens, the lens that you bring, and the trust that needs to be restored between institutions, including the City of Toronto and every institution in society and communities that have been harmed by institutions in the past. So I just want to thank you for that, and I will be supporting Councillor Thompson's motion. I look forward to your expertise and your continuing partnership here, and I just want to congratulate you again.
Thank you. Thank you, Councillor Bravo. Okay, I guess I can speak. Is there anyone else? Okay. Councillor, I don't know why I call you Councillor. Director Azude, go ahead.
I want to thank you again so much for your work, including the brothers at the Water Foundation. I actually did a project with you a couple of years ago, remember? We Speak with HIV. And it occurred to me that obviously I am a Black man, and even though I'm under 40, hopefully I will be over 40 sometime, and I will be at risk of prostate cancer. So I was thinking a couple of weeks, I asked some of my Black friends, male friends, I said, oh, do you guys have family doctors? And just one of them did. It was about four guys. So that was disheartening. And so I just wanted to bring it up because as much as the work that you're doing now is for, it has an age risk aspect to it, it would be very much helpful if you can also bring some awareness to the young people, right? The young Black people. And just like the doctor was saying, you never know, because it may be targeted to the young Black men, but information spreads, things disseminate, and everyone else may also get that information. And I see that, we had a letter from the Toronto Youth Cabinet, so that may be one area to look into, to engage, just to get some of the young folks talking about this stuff. And we're not going to be young forever, so it can never be too early to talk about health. So thank you.
Thank you. And I guess I will go next. So I do have a motion Staff can put it on the screen. Thank you. Thank you. So in their report, so many papers here, it's crazy. In the report on the Black Scientist Task Force, they are a guest of the Board of Health here today. So their recommendations, which they spoke to, they cannot bring to the fore themselves. So I'm bringing it forth as a member of the Board of Health, the 6 recommendations which they spoke to already. 3 of those are given direction to the Medical Office of Health, and the last 3 really talked about requesting things from the Ontario government. And again, if you look at item number 2, for example, it does talk about mental health and addiction, which we spend a lot of time talking about here today. And it's all intersects in a way that I feel is really important. So I won't speak to it any further because they've done a great job explaining it themselves. But I just wanted to say thank you again for your hard work and your dedication to this project. And hopefully we'll see the outcomes that we hope over time. So thanks again. Councillor Thompson.
Chair, thank you. With respect to further consultation and discussion with Dr. Davila and Ms. Campbell, I'd like to just amend the motion that I'd move, which is to add the word Black Health Secretariat. We had just established that it was just simply Secretariat Task Force, but I think the word health needs to be incorporated in that, so I've just made the adjustment to the motion.
Yeah, thank you for that change. And so seeing no other speakers on this item, we can go to the vote. First with Councillor Thompson's motion. I believe you wanted a recorded vote? Yes. Sure, split up. Unless you need...
This is a recorded vote on motion 1 moved by Director Thompson on item HL 3.3. When I call your name, please indicate your vote. Director Bravo?
In favor.
Director Chandrabalan?
In favor.
Director Kretschmer?
In favor.
Director Malik?
In favor.
Director Moyes?
In favor.
Director Ozude?
In favor.
Director Perks?
In favor.
Director Roy?
In favor.
Director Singh?
In favor.
Director Shrish Kandaraja?
In favor.
Director Thompson?
In favor.
And Director Zhao?
In favor.
Thank you. The motion carries unanimously.
Thank you, Madam Clerk. And so my item is next. All those in favor? All those opposed? And that's carried. Thank you. The next item, the last item for today is item HL 3.4, Toronto Public Health 2023 Risk Management Report. We do have one deputant for this item, and it is Mariko Uday. Are you still here? You want to come to the front here? You have 5 minutes to present, depute to the Board of Health.
Hi again. I'm here to depute regarding the Toronto Public Health 2023 Risk Management Report, and it identifies vaccine hesitancy as a problem or risk. And it might be a bit of a stretch here, but I'm here to encourage you to think instead of vaccine hesitancy as an opportunity or asset. For instance, if a vaccine is not perfectly safe or effective, isn't it good to have a portion of society that is skeptical and asks questions? My PhD work was on how to design cities and neighborhoods to be sustainable and resilient, and part of it involved collecting strategies for resilience. So this work identified 2 resilience strategies that I think are relevant here. One is social cohesion. To get through a crisis, it helps to have a society that is united on the same page and singing from the same song. The other is diversity. In a crisis, it is critical to have a diversity of options and approaches, not just a single one in case that single one fails. So then I was confused because both of these strategies are like opposites of each other. Which one is it? And then I realized, well, actually you need both. And finding the balance is the trick. If you have 100% cohesion, then you're on the same page, but you risk the catastrophe if a differing viewpoint would have been life-saving. And then if you have, on the other hand, 100% diversity, then you have like everyone scattered in different directions, and a societal goal may not be accomplished. In the past 3 years with COVID-19, we've been subjected, we've taken a very much top-down approach where the WHO dictates recommendations, and then the FDA, CDC, and Health Canada approve, and then the provinces, cities, and citizens follow, and there hasn't been much variance. And the vaccine hesitant and vaccine hesitancy has been framed as a problem to be stamped out. I.e. cohesion at the expense of diversity. And I believe that this has been harmful to the vaccine hesitant and also to society as a whole with all the division. So I'm asking, encouraging us to invite a little bit of diversity, debate, and discussion back into the mix. A first step could be to frame vaccine hesitancy not as a problem or risk, but as an asset, and maybe even welcome or embrace it. And then together we can work together with cohesion and diversity towards a more resilient Toronto. Thank you.
Thank you very much. Any questions for the Deputy? Okay, seeing none, thank you so much for your coming in today. Any questions of staff on this item? Seeing none. Any speakers? Seeing none. All those in favor of receipt? All those opposed? That's carried. Thank you very much, everyone, for coming in today, and thank you. You guys are awesome, and see you next month. The meeting is adjourned.